Dua nambah. Cek. Cek. One, two. Halo. Cek. Halo. Halo. One, two. One. एक चेक कर. One, two. चेक. हेलो हेलो हेलो. इसका बेस स्पीकर. बेस चेक. वन टू. हाँ. हेलो. चेक. बेस. वन टू. टू. हेलो हेलो. सर वो साउंड भी चेक कर लो कि वहां जा रही है, क्लियर आ रही है. लेवल काले हो गया. क्या मिलता गया. आ रहा है जा रहा है.
फोर्स कम, रेडिएशन कम कर दो कैमरे की। नहीं आई। केवल एक बढ़िया रेजोल्यूशन कम करो ना भैया। आपका आ रहा है जा, रेजोल्यूशन कम करो उसका। लैपटॉप का सबका आ रहा है, सब लैपटॉप का आ रहा है। आपका तो और कम है, 220। ठीक है। ठीक है, वो तो सुना। हेलो हेलो।
Hello. Hello. A very good morning to everyone. In this health summit, I, as a president of National Indian Medical Association, and Dr. Alex, the founder president of AHPI, welcome you all in this summit, and we expect a very good output out of this summit. With this, I request our MOIC to please come and start the first session. Dr. Vani? So, Dr. Alex, come please. So now it's. Thank you. Good morning, ladies and gentlemen.
A very good morning to all of you.
It's a pleasure to compare this day's event, Dr. Vani Puri Rawat and myself, Dr. Shanmuganandan. I'm sure we'll be able to give you an interesting session the whole day and come out with some meaningful facts which is likely to change the course of patient-doctor relationship in our country and ultimately healthcare. Thank you very much, ma'am. This National Health Summit 2023 is jointly organized by the Indian Medical Association, the Association of Healthcare Providers India, Nat Health, Consortium of Accredited Hospitals Organization, and associated ANBI. Ladies and gentlemen, the theme for today's health summit is harassment to the healthcare professionals, how are we going to combat it and bring back the glory of the medical profession. Today's summit will flow in this manner. We have a plenary session. The topic being closing doctor-patient relationship and how it has impacted delivery of care in our country. Following that, we have 4 sessions. The technical session 1 would be on analyzing root cause of violence against healthcare professionals and institutions. The technical session 2 will be preventive and mitigative strategies. The session 3 would be on legal and ethical perspectives. And the 4th session will be on building an environment of safety within hospital. Following that will be the inaugural session, wherein the chief guest will be Dr. Jitendra Singh, the Minister of State, Ministry of Science and Technology. Following that will be the panel discussion on advocacy and lobbying with the government, regulatory agencies, and community at large. Then we have the valedictory function, and we close with that. Ladies and gentlemen, it's my privilege to request all the chairs, co-chairs, and the speakers to ensure that we bring down the curtains on this National Health Summit by 4:45, 4:45, so that many of us who are here would not miss our flights. And certain important announcements to be made. The guidelines for the chairperson and the co-chairperson. Each speaker is allotted 15 minutes, and at the end of 12 minutes, you will hear a buzzer, And 3 minutes from there on, the speaker would be requested to close his presentation, unfortunately. Then the chairperson will introduce the topic, introduce the speaker, and manage the session within the allotted time. He is given 3 minutes. The co-chair is given 2 minutes. He will invite questions from the audience, and the number of questions will depend upon the availability of time. And within those 2 minutes, we request him to complete the whole process. This question of patient-doctor relationship is a very interesting exercise that goes on between the doctor and the patient. We begin this National Health Summit with a very interesting quotation by Dr. Morgan Martin. To quote, "The physician treats with words. Within the physician-patient social system, the patient is moved by fears and other sentiments, and these are modified by the physician's words and phrases. Physicians dispense not only medicines, but words that influence medicines or all by themselves that affect the patient more than the medicine." Unquote. I think that very aptly portrays what happens during the patient-doctor relationship. And with that, I have the great privilege of starting with a plenary session tracing doctor-patient relationship and how it has impacted the delivery of care in our country. The chairperson for this is Dr. Naveen Dang. Can I have him on the dais, please? The founder and director of the Dr. Dang's Lab and member NATCAL. The co-chair would be Dr. Girish Tyagi, Registrar DMC. I think he's yet to join us. The speakers would be Dr. K.K. Talwar, who will be giving us the historical perspective. Dr. Talwar, sir, please. And Dr. Randeep Guleria. And with that, over to the chairperson. Thank you, sir.
Good morning, all of you. And I'm very grateful to IMA and, of course, to Nat Health, which is one of the largest organizations of healthcare providers in the country, for giving me the privilege and honor of chairing this extremely important session. No doctor, I speak from the heart, no doctor, howsoever competent he may be, howsoever honest he may be, howsoever diligent he may be, howsoever committed he may be, has at least faced violence once in the span of his career. It is so sad that there has been a total breakdown of the patient-doctor trust relationship. Unfortunately, things have changed with time. I became a doctor. I think we all became doctors with the concept that we are going to provide service, serve the poor, serve the patients of all categories, of all classes. There was a strong bond between the patient and doctors. I'm going to get a little personal, if you permit me saying so. I remember a few years back, there was a patient who came to me and I told him, "Yeah, please go and show yourself to Dr. Randeep Guleria." He was shown to J.S. Guleria. He said, "No, Dr. Dang, I still have confidence, Dr. J.S. Guleria. Even if he touches my hand, just sees my pulse, just examines my BP, I'll become all right." I do not have that faith in the younger generation. Why this? Why this all evolved? when we were all considered to be just sort of what you said, doctor to Bhagwan ka roop hota hai. But things have totally changed. And most of us are not keen at all that the next generation of ours should enter into the medical profession. Not me, but I still believe in our profession. I'm still sure that we will avail. We are still sure that we'll be able to instill that confidence back into the patients. And that is why we are all here. I remember it was in 1986 when the Consumer Protection Act came. That was the one nail which destroyed the patient-doctor relationship. I remember Dr. Vinay Agarwal who's here out here telling me the same thing in 1986, but I simply did not believe it. I thought we'll be able to prevail, but no. Now we are traders. Now we are service providers. Every patient has the right to question us. Every patient has the right to blackmail us. Every patient has the right to threaten us. So much so, when I was driving down out here, I got a message on my phone saying, "Are you blokes open today?" Can you imagine? After 40 years of practice, I was told this by a patient, "Are you blokes open today?" Could not have been one respectful word. It again, I said, I'm going to an IMA organization where we are going to be dealing with similar problem. That why is that respect gone? Was it only the Consumer Forum Act, or there were other factors also? Do you have a solution to them? Can we solve them? Can we retain our glory which has been lost? I'm quite sure with all of us combined together, we will prevail. We shall be able to do it. I have the privilege of introducing the first speaker, Dr. Randeep Guleria, Dr. Talwar. Sorry, the first speaker, Dr. Talwar. Dr. Talwar, a teacher, a guru of mine, whom I have the privilege of being in PGI Chandigarh when he was the director. Before that, he was the head of cardiology in All India Institute of Medical Sciences. And of course, with his vast experience as as the chairman of the board of governors of Medical Council of India, has experienced so many ups and downs and has had the what I can say fortune or misfortune of dealing with different kind of problems which the medical profession has faced. At the moment, Dr. Talwar is the chairman of PSRA Institute, chairman of cardiology of PSRA Institute, and I hand the mic over to him to take the discussion forward and enlighten us so that by the end of the day, we are more wiser than what we are now. Thank you, Dr. Talwar. Please carry on.
Good morning, everyone. Thank you, Dr. Dang, for your kind words. I also first must express my gratitude to Dr. Alex and Dr. Agarwal for this opportunity and invitation. I think this topic of doctor and patient relationship, I think one has worked as a clinician for the last over 45 years and have been dealt with the patients of all kinds, first in public sector mostly, and then now also have exposure to the private sector. I think I'd like to share with you my thoughts in the next 15 minutes on this particular aspect. You see, the doctor-patient relation constitutes an, I think, important aspect of medical treatment, the medical success treatment. In our culture, it has been always considered as a sacred and very pious relation. Doctor is not only a healer,
ये वाला चल रहा है
see, doctor, ये चल रहा है. The doctor is not only a healer, the doctor is not only a healer, but a friend and a well. I think this relation has a based on four elements without you. The trust, the confidence, the loyalty, and not regard.
Mic is not working.
That's fine. I think father of Indian system of medicine, Charkadi said, good doctor nurtures affection for his parents, for his patients like a mother, the father, brother, sister. Physician having such qualities gives life to the patient and cures their diseases. It's all because of this the patient considers doctors next to God. I will also like to say that we are really not next to God, but anyway, of course, the trust in all culture has been very sacred. For example, whenever you ask a patient for a consent, देखो ये करना है ये he always say, doctor, do what you feel the best. He leaves on it to you just because of his faith, his trust, abundant trust there or blind trust that he has in his physician. He leaves it to you. He says, you are my best, but please do what you feel is best for me. Of course, this relationship has now shifted from a blind trust to a mistrust, and sometimes even he tries to question you. Of course, this has tremendously, as Dr. Dan has said, affected the practice of medicine. I think effectively we look at which are the ones which have really affected these relations are important, like some poor patient, poor prognosis, complication during surgery, procedure, time constraints, physician burnout, the cost, conflict in the treatment team, and of course the language barrier. These are some of the issues, and I'd like to let us examine with you what are these gaps which I feel are important and we need to work on that. The most important, I think, has been the commercialization of the medicine. This is only happened after the corporate sector has started. This was never so in 60s, 70s, 80s. Many of our own colleagues who opened nursing homes in cities, urban people had blind faith in them. It's only with the commercialization, with this corporate hospital which has come up that has really affected. Dr. P.M. Bhargava was a very known scientist of the country. He was the founder of CCMB, that is Center for Cellular Molecular Biology, the first institution in the country in Hyderabad. In one of his own address in a convocation into a health university, he mentioned, I'm just quoting his sentences, that the patient perceives that the primary objective of the most corporate hospital is to get the maximum money from the patient by giving the minimum possible in return that they can get away with. I mean, this was his own personal experience. The billing to the patients in these corporate hospitals are neither fair nor transparent. Most of our patients are not insured and thus they have to pay from the pocket, and that pinches them. So we have tried to borrow this culture from West, but I think we have our own limitations. Some of the, just to add more, these hospitals, they have some unnecessary diagnostic tests, surgical procedures, stay in the hospital. These are some of the practices, I think, which probably are resorted and has created a little sort of the patient's conflict in his mind. Kickbacks for referring, or somebody even mentioned referral commission. I think this is something which when I joined the private sector, I was surprised. Even today, if you do a procedure, somebody referred a patient, he gets a sizable referral money without doing anything. Now, this is in the patient's knowledge. And what the cost, the private hospital will pass on the cost to the patients. So I think these are some of the factors which are, and then sometimes the nexus between drug companies and doctors, I think we are aware from the media. When I was a chairman of medical council, I had to face this kind of situation from some subgroup. So this mutual trust relation has now converted into business transaction with corporate setup. People are moving towards the hospital brand. So I think individual earlier they faced were the doctors, but now I think they are taking this sort of people go to the hospital just because the brand. And I think there's a need to that these institutions have to realize the sort of the sanctity of this profession. The second issue, which gap, I think the communication gap and bedside manner, which I think Gloria is going to deal with. I'm not going to touch much on that, except to say that any miscommunication, even to the patient, hospital administration, billing section, admission section, I mean, these all affect the mind of the person. Bedside manners, I think, are very, very vital. We all learn the bedside manner from our teacher during rounds. And I think how important it is to deal with the people. I think there's a very movie, Doctor, which came in 91. I have not seen myself, but this is a Dr. Ed Rosenbaum, who was an internist and a rheumatologist. This wrote his biography in 1988, A Taste of My Own Medicine. When the doctor becomes a patient, to seeing to bear this out, he practiced for 50 years before becoming a patient in the same hospital where he used to work. It was not until then that I had learned that the physician and the patient are not on the same track. The view is different when you are standing on the side of the bed from when you are lying on it. So I think you have to, and as always frankly felt in practice, when you're dealing with a patient, that if I am the patient, what will I expect from my doctor? So you try to see from that angle, see how you can deliver the service. I think it's a very important movie. I'm sure that you try to let that how when a doctor becomes a patient, how do you realize what the feelings of the patients. The third word, which Dr. Dang you mentioned, is the CPA, Consumer Protection Act. And I think this is, I have written a chapter in the book which Dr. Alex and Dr. Agarwal, Dr. Sadhanaji wrote, edited this book on that. This is one act I think has been the probably beginning of mistrust between the patient and the doctors. The Supreme Court decision, I think initially, I'm sure all of you must be knowing, that 86, when this act came, the medical community was not considered to be part of this act. It was only 94, the Supreme Court judgment, when they said, no, doctor is a service provider and the patient is a consumer. I think they sort of this inclusion of thus holy relation between the patient and the doctor had been seriously affected by this particular act. The inclusion of doctor in the legal regime of the consumer protection has not led to a mushrooming of unnecessary investigation, inquiries, litigation, and the patient and families' expectation have also grown. There is sometimes a very delicate balance between expectation of the patient and reality. Then how to address to the patient who we are not God, even next to God, to cure everyone? The outcome depends upon the quality of treatment, no doubt, but also depends upon the kind and severity of the disease, associated comorbidities, unpredictable effect of therapy, and inherent limitation of medicine. Over expectation even leads to anger and violence, sometimes that has been we are facing. This has also made the practice of medicine to be defensive, writing news and more investigation, which only add to the cost. Unfortunately, people are routinely approaching the consumers for in the hope of monetary awards. The litigation go on gradually for years, adversely affecting the professional career. All this fosters the feeling of mistrust or distrust between the doctor and the patient and taints the most holy of human association. Even naturally arising complications during the course of treatment or procedures are viewed through the lens of suspicion. The negligence, they're thought to be that a negligent act, or worse even, we lose sight of the simple scientific truth that one straight jacket cannot fit all. The effect of same medicine, for example, may vary in different individuals. We have forgotten to our detriment the insightful words of father of allopathic medicine, Dr. William Osler, who said, medicine is a science of uncertainty and an art of probability. So we cannot be sure of giving cure to everyone. No doctor gains from anything by acting negligently. Ordinarily, every doctor would act to the best of his or her judgment and alleviate to the extent possible the suffering of any patient. And the threat or fear of legal proceeding, of course, when are there, does affect your mind when you're approaching a patient. So I think these are some of the concerns. Of course, the another factor is the health care is becoming technologically and scientifically more advanced. It is also becoming impersonal and also contributing to affecting the doctor-patient relations. But these are the few factors, frankly, that I think has been the reason. And I like to say that what we should do. And it's our challenge, and we all have to work hard to, I think, that this is what when Satyadev Jayate, Amir Khan called me, I gave him, but unfortunately, he cut off that statement. Later on, I met him and asked him, you appreciated that this is doing sort of, most of the doctors have been very working hard, faithful to their patients. But I mean, so this is our challenge that we have to see. And I like to say that there are two ways. And one is the duty of individual, one of us, every one of us. And I think the next part is our family or IMA family, that what we should do. Now, as far as it's important that they say medicine is a science, but art is the practice is an art. We must learn this art. And as I said that we learn this art from our seniors to teacher during their rounds. Now, that is one area we need to teach to our youngsters. Well, and you have to be very patient should feel confident when you approach him. Your bedside manners. They say maintain your eye contact with the patients, and this communicates care and compassion, involvement in decision making, emotional support, empathy, respect for the family, for the patient, continuity of care. Listen to the family. I think that may help to remove their concern and anger. So it's important to, I think, create a doctor-patient relation important to establish by trust, confidence, and respect for each other. Friendly, competent decisions not affected by commercial angle will give necessary care and sympathy. Patient and family should not feel that doctor is drawing undue mileage. I think this is one, sometimes they feel that it's over kiya ja raha hai. Identifying and legitimizing patient concern and worries without offering false reassurances can help and comfort the patient. It puts them to at least by doing that the physician has commitment to them and recognizes their emotions. Now, I think I will use this opportunity. We have the August gathering, I am a family, which I think we as a profession look forward to sort of protect. I'm sure you all agree with me. Medicine was the most prime profession when we were about to enter. Most sought after. Today, bright students are hesitant to come to medicine. The second part I'll mention to you that even if you look in I don't know whether some of you may know that last year, 150 DM and National Board cardiology seats were vacant. Nobody opted for it. So I think we need to wonder why this is all happening. It's not that the youngsters don't want to come to this. This is very local for everyone, but we have to give them confidence, the environment, so they can work with the confidence and that probably that we are growing. I like to just close these few things. IMA should make effort to impress upon our colleague to discourage referral commission system. I think we should make it a kind of this is something which is affecting, and they will give us a lot of confidence in society. Medical insurance, maybe the IMA will sort of convince the government to have a subsidized medical insurance. We have Ayushman Bharat, but 60% of the population, which is a medium society, has a problem. So some kind of insurance help to them. We will again one other way. Of course, the CPA Act. I think this is one act. IMA should make effort with the government to relook at the CPA and medical services. It is my view that the wisdom of including medical services within the purview of such legislation needs to be urgently debated and revisited. Experience has shown that the application of CPA to medical services is counterproductive. It has weakened and worsened the doctor-patient relationship rather than strengthening it. A revamp of the current system is overdue. and a more efficient and balanced system must be placed. A new system should be geared, people should know that there's some accountability, should be geared to provide more optimal outcomes of all stakeholders, patients, and doctors alike. Safety for patient and his family, fairness for the doctor must be twin guiding lives of this. A system which implements a steady and credible decision-making process with outcomes steered by scientific evidences is the need of the hour. Let us not blindly follow American litigative culture, which has only added to the commercialization of a noble profession like medicine. Instead, India should lead the way and emerge as a role model for the rest of the world for this. The hospital, of course, I think there should be medical audit board in every institution. As you have an ethical committee is mandatory, we should have medical audit also in it. Each should be analyzed. This will give you more transparency and confidence to the society. Of course, the hospital today must have a active care support section so that people can sort of be their anxiety, their concerns can be addressed. Medical doctors may not be able to handle everything. So this is one area, instead of calling marketing section in the hospital, they should have active care support system sections. I think these are some of the telehealth is another area. We can follow-up visit can be done, which will give a lot of help to the society, the patients. And I think the medical profession is a crossroad. We have a lot of hopes in our IMA body. So I can make sure that we get back, we grow this profession back. And let us, again, I would say the work to preserve the soul of this noble profession, and there's a good doctor-patient relationship. Thank you so much.
Thank you, Dr. Talwar, for a very interesting 15-minute topic that you spoke upon. Yes, you're right. Everything is now transactional, if you permit me to say so. Patient comes, they say, we have this problem, you deliver. If you don't deliver, we are unhappy. If we are unhappy, we'll take action against you. Under that fear of threat, under that fear of litigation, how can we work properly? How can we give the best possible? So we ask for a second opinion. And they're annoyed that why we're asking for a second opinion. We put our clinical skills in the background and depend a lot on evidence-based medicines, like maybe a lab test or maybe radiology or anything like that. So we are forced to do that. That increases the cost burden on the patient. And that is again questioned. There's no thank you. We are supposed to deliver. They are paying. If we do not deliver, we are the culprits. We are at fault without realizing that medicine is not an exact science. It requires lots and lots of efforts, lots and lots of reading, lots and lots of clinical acumen. Even with the best, still there are times when we may not be able to deliver. Dr. Guleria. Dr. Randeep Guleria is not only the former director of All India Institute of Medical Sciences, and at the moment, the chairman of internal medicine in Medanta, and also looking after the medical education, but also an extremely dear friend who, I'll say, led the fight against COVID. And it was during the COVID days, as Dr. Guleria can well understand and say, that we suffered a significant or a very large amount or very large number of medical violence. The demand was more. We had our own limitations. Everybody wanted the result immediately. The results were questioned. There was so much of a pressure on all of us. And I think the maximum pressure was on Dr. Guleria to deliver. But do you know, if we think retrospectively, that we did deliver, we did succeed, all of us sitting out here without masks on. Dr. Guleria, please, I have the highest regard for him, for what he did and what he's continuing to do. And I was and will always remain a great admirer and a fan of Dr. Guleria. Dr. Guleria, please.
Thank you, Dr. Dan, for your kind words. Good morning, everybody. I'd like to take this opportunity to really thank the Indian Medical Association, especially Dr. Vinay Agarwal, for inviting me on this National Health Summit. I've been asked to talk for the next 15 minutes on advancements in communication when we start looking at medical health. And when I thought about this topic, I thought I could divide it into three broad sections: the good, the bad, and the ugly. So I'll start off with what was the good that we've seen as far as advancements in communication is concerned. I think what we must realize that the last 60 years have changed medicine like never before. What we've seen in our lifetime, probably people did not see in in centuries. And I give one example which is not related to medicine, but which actually sort of gives that an idea of the change that we've seen. When I was a resident in PGI, if I had to talk to my parents in Delhi, I had to go to Sector 17, book a trunk call, sit for 2 hours, and then have the operator tell me, "Jor se baat karo," and get that crackling line to be able to talk from Chandigarh to Delhi. I could have never imagined at that point in time as a resident that where you would have a time and you could do all of this virtually, looking at talking to people across the world, FaceTiming with them, and doing that with just a small device which was at the palm of your hands. That is the type of things that we've seen in our generation. So the advancements that have occurred in medicine have been phenomenal. We have had now what is known as the fourth industrial revolution. We're living through that, where let's say the gap between physical and virtual reality is actually merging into one. And because of that, we have the Internet of Things, wearable devices. All of us can now see our ECG, our pulse rate, our saturation with our watch. We have robotics, 3D printings. We have big data analysis. And that is actually changing how science and research is being done. And there is also augmented reality, which is coming in a big way as far as healthcare is concerned. So this has fundamentally altered the work and relationship between patients and doctors. From being totally a physical sort of relationship, we are moving more and more into a virtual relationship. We saw that in COVID. Most of our OPDs were run virtually. A lot of our chronic disease patients were managed through a virtual telehealth platform. And even with patients who had COVID, who had home isolation, a lot of their monitoring in terms of their saturation, in terms of the breathlessness and symptoms was done basically, management was done basically through a virtual platform rather than what we saw as a physical platform. But this is also, all of this change, all of this churning in a way has actually changed the way patients also communicate with us. And patients have become more aware, and the approach in healthcare has become more and more patient-centric. Alvin Toffler has written a book which is known as the Patient Will See You Now. And that book amplifies how patients have become more and more aware, and there is now the need for shared decision when it comes to managing our patients. As a matter of fact, in that book, he really gives examples of how patients went to the internet and searched the net and came out with their diagnosis rather than what the doctor was doing. But that has changed how we are able to communicate with our patient. I mean, today you will see patients, either they or the relatives have already Googled their disease, their diagnosis, and you have to communicate in a different manner with them because of the fact that they are started questioning you more regarding the disease that they have or the symptoms that they have. And therefore, this is something which in a way is good because it helps in better communication, it helps in better knowledge, but it also has challenges, and that is what we also need to be aware of. In the future, because of better communication, because of better technology, I think we will be able to prevent diseases early, predict events much more in a faster manner, whether it be an acute coronary event or an exacerbation of any chronic disease. We will be able to have early detection, and I'm sure this will improve healthcare delivery as a whole. But in all of this advancement that we're seeing in the science of medicine, what we've forgotten is that there's an art of medicine also. And the art of medicine is equally important in communication as is the science of medicine. When you're ill, and when any of us is ill, it's not that we don't need a doctor. You still want a doctor you can trust and communicate with. And I think that is the crux of medicine, which somehow has become less and less sort of important over the last 15, 20 years because of technology taking over medicine and it becoming more and more from clinical medicine to investigative medicine. And because of that, communication has become much less. We hear our patients, but we don't listen to them. And listening is something which is more important than hearing what our patients are saying. It requires hearing is more accidental, it's involuntary, it's effortless. But listening is something which requires a lot of effort. It's voluntary, it needs a lot of concentration. And when you listen to your patients, it's not just listening to what they are saying, it's listening with your eyes also, it's listening with your heart, with your brain, and picking up the cues that the patient may be giving in terms of the problem that he's facing. Sometimes what the patient doesn't tell you is as important as what the patient tells you when you communicate with your patient. And that is what we're missing out. So this is the bad part of what has happened as far as communication is concerned, that not all communication is verbal. And we need to really listen to our patients. And as like Professor Talwar said, that is what was really taught as far as bedside manners or bedside teaching in medicine was there. How do you properly listen to your patients and understand the history that they're giving you? William Oscar said, listen to your patients, he's telling you the diagnosis. I think that is something that we're losing out as far as communication is concerned. And this has actually, what is the bad part, has changed medicine in a big way. William Oscar also said, and I think he made very profound statements which are very relevant today. And he said the practice of medicine is an art, not a trade, a calling, not a business, a calling in which your heart will be exercised equally with your head. Often the best part of your work will have nothing to do with the potions and powder. So the best part of medicine has got nothing to do with what you give your patients. It's how you communicate with your patients, how you empathize with your patients. And all of that has changed as medicine has advanced. And this is what we really need to see. How can we really bring that back as far as the trust is concerned and the communication is concerned? What has happened, and because of all of this, as was mentioned by Professor Dalwar, the trust between the doctor and the patient has changed. Whenever you ask for some investigation, there is a whole feeling that is it being done from a commercial point of view rather than what is required for the patient. And that, I think, has all further eroded the trust and the communication that one is able to have as far as the patients are concerned. How can we change this? And I think there is now a need for all of us to really see that how can we bring back better communication with the advancement in technology and science that has happened. And that needs to be taught to the younger generation. We have not really focused on better communication skills with the newer technology that is available. There is no teaching in medical college on this. There is no real learning that happens. And all of that was taught at the bedside has now become less and less. Even if you go and see in various hospitals, and this is not only in the corporate hospital, but even in government hospital, a lot of time what is really looked at is more of the reports rather than examining the patient. This is something which is changing. If you see the hospitals, you'll have more during the round, most of the residents actually scrolling through their phone and looking at the reports rather than actually examining the patient to see is there bronchial breathing, are there is the patient having bronchi, is the liver or spleen palpable. I don't think anyone really looks at neurological signs anymore. How many of the residents actually have looked at whether a plantar is upgoing or not to really make a diagnosis? And that is the art which I think of examining a patient that we're forgetting. But that is also to do a lot as far as communication and communication skills are concerned. So if we are going to move forward in this, the science of medicine, we need to see how can we change the art of medicine with this change in technology so that the patient doctor trust can still stay as firm as it was 20, 30 years ago when I used to make trunk calls rather than do FaceTime. So that is what we really need to look at, that how can we bridge that gap which has happened in the last 20, 30 years. A lot of times now people talk of communication, which is important when you discuss the diagnosis. People say that now there should be shared decision. And the quote that is there is nothing about me without me. Meaning that patient would say that nothing should be done about my illness or myself without me being informed or without me being part of it. And if we are going to have that, then it's very, very important we understand how can we better communicate with the current technology that is available, but still be able to build up a trust which we have lost as far as patients are concerned. I think what has happened is that the internet and the knowledge that has come in the last few years has dramatically changed how medicine is being practiced. As a matter of fact, it's been said that the last 2 years have seen more knowledge or more information being available than in the entire history of medicine over centuries. So what type of knowledge that we're getting in the last 2 years is like never before in terms of what is available through the net. If you were to look at what happened during COVID, you had n number of messages to the social media, and you didn't not only did you have a pandemic of a virus, you had an infodemic of information, and sometimes it was more challenging to handle the infodemic of information, which was creating more panic situation rather than the pandemic created by the virus. So when we are having this whole surge of information, how can we better communicate with our patients so that the trust can be brought back? I think is very, very, very important. So I'll stop here, and I think this is food for thought. So thank you very much for giving me an opportunity to talk. Thank you.
Thank you, Thank you, Dr. Guleria, for an extremely interesting concept, what you have spoken about. Yes, you are right. There have been so many external factors which have affected the breaking of this patient-doctor relationship trust. And as you have rightly said also, that there's something called a differential diagnosis, where the patient fails to understand or refuses to understand. Corporatization has again been one more factor. Increasing cost has been one more factor. But again, as everything is transactional, so we also have to look at it from a very different perspective, which we don't want to. We still want to treat our patients the way we were taught to treat them as if it is not only a duty, as if it is a religion. So that is the way we will continue to work, and let's see how time progresses. Dr. Girish Tyagi, I would like you to say 2 words, please, and take it forward from here.
Thank you, Dr. Guleria, Dr. Palwar. First of all, congratulations to IMA, AHP, and other organizations involved with that to organize this national summit. And starting with a session on doctor-patient relationship. As our speakers, Dr. Naveen already told about that doctor-patient relationship, which was supposed to be a pious one based on trust and faith, now it has been on the mistrust, and of course, pious relationship always has gone. Doctor, which was supposed to be at one time treated as equal to the God, now this just it is a other way around. And the factors, of course, we have our speakers have started about. One is that starting from that Consumer Protection Act 1996, then came that VP Shanta versus IMA judgment, then which brings into the ambit of commercial act to that doctors. Then of course the situation altogether changed. Doctors has to do the defensive medicine, started defensive medicine, more investigation, more test, more medicines. Then of course the cost automatically becomes increased. And because of that, the litigation, assault, these kind of issues started increases at Delhi Medical Council. And communication was, as Dr. Guleria told, what the communication plays a very important role. And we doctors are not communicators at all, because at least at Delhi Medical Council, which we received the complaint, at least 65 to 70% of the complaints are because of communication only, communication and behavior only. As Dr. Guleria told that we are examining the patient, and simultaneously we are looking at our mobile, and so it is the patient also think that doctor is not giving proper attention to him. So communication should be two-way communication. We should ask the patient, we should give liberty to the patient or the leader to ask questions, and then we have to satisfy them also. Nowadays the patients are aware ones. Gone are the days then when the patients are just listening in your whatever you say, they will follow that. Now they want to be involved with the treatment. They want doctors should address them. They, whatever their queries are, they should be addressed with us. So communication is more important. Of course, it has become, and role of media. Role of media is very, very important. Media is totally projecting doctors as a villain. Whether a patient treated by a quack, died by a quack, they'll go on in the media that doctor has killed that patient, doctor has murdered that patient. And sometimes at the nursing home or the hospital, whenever the mishappening occurs, media project this as a sensation report just to increase the TRP without taking the views of doctor, without taking the views of the nursing home, they just air the news. And of course, our doctors are also equally responsible. I can say that we are communication plus comments of other colleagues, comments of us. Whenever a patient goes from one doctor to another doctor, that doctor without sometimes communicating, sometimes just without communicating from the body language, he throws the prescription of that previous doctor, the message is being to that concerned doctor, the concerned patient that something has wrong been done, something with the prescription or these kind of issues. So once again, I congratulate IMA for organizing this health summit. My best wishes to them. Thank you.
Can we take questions now, sir?
Well, sir, I think we are beyond schedule.
Right, sir.
Like to get the plenary session, we would like to take one or two questions from the audience.
Okay. I'll go by what Dr. Vinay Agarwal is saying, that we'll end the session now. Thank you all for a very attentive hearing and for being with us today. Thank you.
Would like to request the chairperson, co-chairperson, Dr. I would request our national president and Dr. Alexander Thomas to kindly come over to the dais and hand over mementos to the chairperson and the speakers and the co-chairs. With this, the plenary session comes to an end. And over to Dr. Vani. Yeah.
Thank you, sir. Ladies and gentlemen, after this enlightenment plenary session, navigating to our summit further, we commence our next session, which is technical session 1. And it says all about analyzing root cause of violence against healthcare professionals and institutions. We take this privilege to call upon and invite the chairpersons, Dr. Vijay Agarwal, sir, who is President CAHO, and co-chaired by Dr. Chitij Pali, sir, who is the present Finance Secretary of Indian Medical Association Headquarters. We have talk 1 on navigating unmet expectations by Dr. Sanjeev Singh, talk 2 by lack of empowering patients, relatives and caregivers by Dr. Shiv Kumar Utre, talk 3 about socio-economic factors by respected Dr. R.V. Ashokan sir, who is upcoming National President of Indian Medical Association Headquarters. I will take this privilege also to invite the speakers of this session, Dr. Sanjeev Singh, Dr. Shiv Kumar Utre, and Dr. R.V. Ashokan sir. Now, chairpersons, the dais is yours.
Sir, how is sir? How is sir? अच्छी बात है ना, अभी ये रिजल्ट आते आते ना का फोन आ गया टाइम पे आ गया उधर से होगा should we start? Yeah, why not?
So good morning, friends. It is indeed my proud privilege, pleasure to be here, and I'm very grateful to IMA, to HPI, to our friends Dr. Vinay Agarwal, Dr. Alex, Dr. Gyani, to have me here to chair this very, very important session, which is to analyze the root cause of violence against the medical professionals. And I think even in the morning session, whatever was being deliberated was in a way reflective of the root causes, whatever are going on towards the causes for the violence against medical professionals. It's a multifactorial issue. All of us understand that there is not just one simple reason that we can point out. So it is very important to deliberate and to know what can be changed, what cannot be changed, what should be changed within, what kind of an introspection has to be done by the medical fraternity itself, and what kind of a introspection we need to force the community to do to make this change happen. But the violence against medical professionals is a sad reality and which must be tackled. There is no doubt about it. I request my co-chair to add a few words, and then we start with the first one, which is, I would say,
I think you can start with that, sir.
okay. So at the heart of the, I think at the heart of the cause of the violence against is the unmet expectations. That's extremely, extremely, I think, crucial. I congratulate the people for picking up this as a topic and to pick up Dr. Sanjeev Singh to deliberate on it. I think both the things were, sir, absolutely bang on. So over to Dr. Sanjeev Singh, I'll say the
Medical director.
opening batsman. He is the Vikas, our Kohli of the cricket team of medical fraternity. Over to you, Sanjeev, the medical director of Amrita Institute. Anybody who has not seen Amrita Institute should go and see. It's almost like the Taj Mahal of the medical professionals in the country today. Over to you, Sanjeev.
Good morning. Thank you so much, chairpersons, and thank you, Dr. Sharad Agrawal, Dr. Gyani, Dr. Alex, and the whole IMA team for inviting. I will straight away get into the topic, which is navigating unmet expectation. And this is how we would going to cover that. What are the carer, what are the patient roles, and what is changing? So you, in your younger days, I know you are all young, but in your younger days, you would have felt a tingling sensation whenever you had loved someone. Did you do that? There was some butterfly. And what was that tingling sensation? Basically, it was that common sense left your body. So it is very common that the patient comes with a lot of expectation in the hospital, and somehow we need to sort of address. And why we are not able to do that, I'll just touch upon some of the touch points that people like who are in management and administration, they're more concerned about people. They have a lot of attitude. Generally, throughout the country, they're copycats. People like me also have attention deficit. So if you give me raw data and give me 4 paragraphs, I won't be able to read that well. We somehow have the first mover advantage, first in Haryana, first in Faridabad, first in central Faridabad. And is where we generally end. Then we have a group of clinicians who always think they are God's gift to mankind, and they are. They are cultures of individual. Somehow we all want to build teams, but then they are all having disjointed communication. We have been running a university teaching hospital, not for profit, for 25 years, yet we are very hierarchical in our medical rounds. And then there is autonomy which is demanding. Then there are this technical group of people who are vital few, trivial many, who needs a lot of training, and Dr. Shubham is here, who's done fantastic work, but then it's a lot of upscaling is required. This is the other group, which is very obedient, hardworking. They don't require data, but they are very emotional people. So they need to be handled emotionally, but unfortunately, they also have a lot of iteration and training. But post 2012, they also are talking about rights and duties. That's a very Kerala attitude. but that has come across the country. So rights and duties have become very important. Then there is another group of people who are very incredibly trained. Nobody wants to appoint them. Then there is another group of people who outsource their change frequently. We all think that there is one thing which is going to change our life, which is technology and hospital information system. By click of mouse, all data would be available, but it's all garbage in and garbage out. So nothing comes out. And the pain scale with our electronic medical record is always 10 by 10. We want real-time data, but there is none. There is this group who governs how the patient is going to. So sister-in-laws, brother-in-laws, and mother-in-laws, they change every day. They are blissfully unaware. And then they say that there is no information given to them and they create a lot of confusion. And their KPI is basically bill and turnaround time. We don't talk about behavioral change. We are, as Dr. Guleria was mentioning, art of science, art of medicine practice. And then poor patient is left with all these touch points and we are not able to deliver. So what do they want? So best of the Amazon has a fantastic tagline, their customer obsession. And I think there is where we do want clinical excellence, we do want academic excellence, but we also want service excellence, unfortunately, which is deteriorating. So some of the important, Deloitte presented this in 2021, that quality of doctor is what they want, keeping them informed is what they want. They want to be having fun on the time, so they all are looking at a 2-minute magazine news approach. The appointment should be scheduled and the bills have to be appropriate. So 5 things which is bothering them. 1, definitely waiting, cost. They need to have a good turnaround time and they need to be sort of listened and heard properly. What happens in India? So black is all qualifiers. We are all doing it. Green is a fantastic winner, but where we fail is all red. There are appointment issues, there are payment issues, and there are websites which don't interact. There are lab tests which doesn't work, and there's a lot of disconnect. Almost similar thing is happening in internationally. So we keep talking about that in India everything fails, but many a times it has failed internationally. So what do we now need to do? We basically need to have a good strategy towards service excellence. We do want revenue. We do want a lot of expectation of return on investment. But to regain that trust, we cannot be always trying to tame public. We also need to introspect internally and do a lot of internal correction. So Napoleon, who was the supreme leader, who wanted to attack Russia and occupy and become again the world leader, started his journey with 1 lakh soldiers. But when he started, that was 0 degrees centigrade. There was no strategy. He just was so powerful that he just wanted to conquer. 75,000 soldiers left at minus 13 degree. 54,000 soldiers left at minus 15 degree. And ultimately, he was left with 4,000 and he lost that battle. So until unless we are planning appropriately and communicating and a shared vision with all the people who are there is impossible. So we need to create culture. So I was attending one of the programs where the cardiovascular thoracic surgeon of Mayo Clinic said, I did operate wrongly. And the patient was sitting next to her. And this was the BBC reporter who was moderating. And the other urologist from Johns Hopkins said that he knew about the report, but he didn't communicate and he didn't treat a multi-drug resistant organisms on time and or tract infection on time, and he lost the patient. And he lost the patient of a husband who's sitting next to her. So those patient journeys are important. So what is this patient journey? So it's basically a unique experience. Can we create memorable moments for patients who come into our setup, other than doing a good curative and good diagnostic and palliative? So can we differentiate ourselves? Can we build a decent loyalty? And can we learn from other industries? How do we work? So this is a typical patient journey when he comes. So he calls, there is website interaction, there are multiple interactions, but most of these interactions don't work. So can we work on that? And then he comes into the hospital, and there is a lot of plan and design which is going to also help. plus he gets admitted and then there's the discharge point. So patient calls to this hospital and then he's put on hold. So all the top lines, he's put on hold. There is a hang, there is an operator who's unable to ask whether a fibroscan can be done, but he has no clue how much it costs. So he's not able to get in the patient. So there are a lot of those gaps which are there. Language definitely is a big problem. It was problem when we saw that in our hospital in Kochi, and calls many a times are dropped. Access to website, it is non-interactive. Everybody claims that it is one of the best websites in the world, but then there is no information, appointments, exploration is a problem. So websites, there are issues. When the patient actually reaches the OP consultation, it looks crowded, the wayfinding is problem, and then there is long waiting time. So is there what we can do? We designed this particular hospital with a similar approach that when it's a patient-centric Mayo Clinic outpatient approach, where when the patient comes in, he comes in into a Mayo Help You concierge area. When he comes in into the lift lobby, if he parks well and he gets into a lift core, he immediately reaches to that particular clinical service. When he reaches there, his registration is done there. His consultations, when registration is done there, his nursing assessment is done there, his consultation is done there, his phlebotomy is done there. If he's giving a fasting sample, cafeteria is there. If he's finishing his consultation, pharmacy is there. And if he's getting any advanced diagnostic, even endoscopy, colonoscopy for that particular area is there in that location. So patient doesn't move at all. In orthopedics and family medicine, even the x-rays are there in the same floor. So we need to have those designs and help patients to. Now, this is my wife, who is a professor of anesthesia and palliative medicine. What happens when they get admitted? So this happens when she was doing her post-graduation. Day zero, daycare procedure of diagnostic ERCP done. One of the best hospitals in the country, one of the best gastroenterologists, entered through ampulla of Vater, got into the pancreatic duct, injected a dye. I'm not talking about day one, day two. I'm talking about month one and month two. Month one, hemorrhagic necrotizing pancreatitis. Month two, subcolic abscesses. Month three, burst abdomen. Cannot close the abdomen post surgery. Month three, pericardial pleural effusion, septic pain. Month five, jejunostomy, persistent high-grade fever, nil per oral for almost 5 months. Month six, we lost her, but then she was hospitalized for almost 6 months, 1.2 CR of bill. The point I'm trying to bring is risk assessments are high. We can avoid all this. So rather than taming the public, there's a lot of internal introspection work which we need to do, which could all have been avoided. We all talk about surgical safety checklist, and we say, moment I show this, everybody says, oh, in my hospital, we all do this. Atul Gawande published this in 2009 in MJM. What he published, basically, we forgot. He published 2.9% reduction in mortality using a checklist. He published 3.2% morbidity reduction using the checklist and 3.9% surgical site survey. So every hospital says we are also doing it. What we do, there is no ethics in our documentation. All checklists are signed as yes, yes. And there is a checklist fatigue because there are multiple checklists which are so. No Indian hospital has yet demonstrated an outcome of reduction in morbidity, mortality in surgical site. And that is where I think we need to also change in the interest. This is a hierarchy of the evidence. So I was doing an assessment of a medical college. A professor of orthopedics came along with me. We saw the first patient, long bone femur fracture. We looked at the drug chart. First drug was injection meropenem. I asked why. He said that is what he has been giving for 15 years. Second drug was injection piperacillin tazobactam. I asked him why. He says 2 powerful antibiotics has to be given. Then only 2 similar mechanism of action antibiotic is being given to this patient. Third drug is injection tramadol. I asked him why, because he says that it's a long surgery, patient will have pain. I asked the patient, do they have pain? Patient said no. Fourth drug was injection ondansetron. I asked why. He said, "Arey, aapko malum nahi hai, tramadol dete hain to ondansetron." I asked the patient, do you have nausea? Patient said no. Fifth drug was 3 pints of normal saline. I asked him why. He says everybody who gets admitted gets intravascular fluid. It has normal saline has been declared as abnormal composition almost a decade back. Sixth drug was injection MVI. I asked him why. He says जब येलो कलर फ्लूइड पेशेंट के पास जाता है तो उसको पावरफुल महसूस होता है. This is where we are. We cannot be just taming public. There is expectation we need to meet, but there is a lot of introspection which we need to do because we are at experience. We are not at meta-analysis level. We need to do a lot of this. My cardiovascular thoracic surgeon was using meropenem, amikacin, linezolid, suggesting that he treats VIP patients. 3 antibiotic surgical prophylaxis. The next cardiovascular thoracic surgeon came in, just gave cefuroxime. His surgical site infections were low. So many a time there is a fear factor which needs to be taken care. And then there are lots of tools. I know I have little time, so I'll skip. There are lots of tools for a lot of good practice which we need to adopt. I'll just spend some time here. Clinical audits needs to be done. We run a very flagship cardiovascular cardiac sciences unit. We measured our work. We have 8 PG residents per year. We measured our work, 6.43 average length of stay. A good average length of stay at AHA is 4.2. Pro-BNP is a marker for suggesting heart failure. We thought it is done 100% of time, done 61% of time. We need to introspect our own work. 55% ACE ARB inhibitor, 100% it needs to be given, was given 55% of the time. At time of discharge, 40% only had ACE and ARB, should be given 100% of the time. Everybody knows heart failure, we need to advise salt water restriction, done only 42% of the time. So there is a lot of work which we need to do internally, and that correction has to be done. So I'll skip. So there is this good book which says, if Disney ran your hospital, how would you run? It is this word which is called as memorable moments and creating memories. There are lots of patients comes with lots of agony, lots of anxiety, lots of experiences which we need to really take care. Two more slides and I'm done. We basically need not repeated training. Training has to be along with behavioral change. So on the left hand side, we were shadowing doctors who were rounding. And we used to track their communication. How do they communicate to the patient? And we realized that it is very hierarchical. The senior surgeon, senior physician only communicates, though the team is there. There is no team medicine practice. And most of the communication, unfortunately, happens with the carer. So my personal understanding is that patient centricity is a Western concept. In India, it is a carer and patient centricity because carer carries a lot of information. And they actually, every good doctor thinks he is a fantastic communicator, but the communication needs to be actually tracked, and we tracked it. We were asked to stop this because the doctors felt very, very bad that they have been shadowed. We had to restart after almost 6 months, and we are seeing a lot of behavioral change in their communication practice. One of these patients, this is a 9-year-old patient. His father was reversing, he was a truck driver, he was reversing his truck, ran over him because he was sleeping, and he crushed the pelvis, crushed the bladder, crushed the rectal, crushed all the muscles, and he was with us almost for 105 days and 18 surgeries. So what we need to do is to create those moments where magical moments where in medicine where team comes together. So there are 3 teams who came together to do this. So I'll end with this. What do I do if my mom gets admitted? I'll show concern. I'll get her early discharge because I need to get my job done ASAP. But what do I do if my mother-in-law gets admitted? Nothing changes. I would look for the top priority, good doctor, evidence-based, be by her bedside, curse everybody in the world who is possible, and keep taking credit that I have got you into an error-free hospital. So can we get more and more hospitals or build more and more hospitals where we can take our mother-in-law? Thank you so much.
So I think a good round of applause for this excellent presentation by. And so Sanjeev, what we have to say, how to build hospitals which can take care of mother-in-laws. That's the root thing that you are trying to tell us. But important thing, what you are saying in this journey to match the unmet expectations is the issue of our, I would say, unmet needs of our training. I think the root cause of whatever you are now trying to say is that we are expecting from our professionals to deliver for which they were not trained. We continue to train them to listen to the bronchial breathing, etc., whatever, which has become irrelevant today, probably. If you think that we are going to reverse that course and all that, that is not going to happen. So the issue is this: technology has seeped into our day-to-day life, and it is better that we accept that technology is impacting and is going to impact more and more the healthcare delivery. And it is very important that right in the medical teaching, right on our day one, this technology has to be understood, and communication which is based on the technology findings have to be kind of now communicated. We have to learn how to take the findings of technology and take it forward. Rather, because no matter whatever you may do, I'm going to look at my iPad or this thing to look at the reports. But the issue is this, that communication with the patient is extremely, extremely important. And that is the part. And we must understand that at the root of it is also that, let's look at the statistics from United States, that even after spending a kind of on the healthcare, which is almost like the GDP of our country, preventable medical error deaths are the third leading cause of death in that country after the heart attack and stroke. Now, you cannot brush it aside. You cannot say that, well, that is not, that can be accepted. And I think even they are failing to understand as to how to crack that situation and problem. So the preventable medical errors are a huge problem. And you can imagine if that is the statistics in a country like United States, what must be happening in our country. We are very, very blessed that we don't have the data. So we can all be very happy and we go on with our life as if nothing is happening wrong. But one thing for sure, which has come up, and this was the World Patient Safety Day, 17 September. The theme this year was to engage with patients, to elevate the patient's voice. And I think that is why the second talk by Dr. Uttare is exactly on this, as to how to empower patients. And I can assure you, ladies and gentlemen, that is definitely one area which is going to reduce medical errors. It will increase patient safety. It will increase patient satisfaction. Over to you, Dr. Uttare, who is a well-known name from Maharashtra. Please go ahead, sir.
After Kohli, Sachin Tendulkar.
Yes, definitely. Sachin Tendulkar, our.
Yeah, thank you. Thank you, Dr. Vijay Agarwal and Dr. Bhagi. And so, I think first of all, I must congratulate you for but when everything is gone, there is discussion, for a future and bring about futures. And I think that is the step that we are taking today by having this summit. So congratulations to Dr. Vijay Agarwal and Dr. Alex for having thought about this summit and calling here today to talk on this important aspect. So empowering patients. Up till now, doctors, nursing staff, of course, most of the Western countries have been empowered. But today we're going to talk about how do we empower patients, because I think all the speakers before have also spoken that it is basically because the patients and the relatives do not know what is happening, and the main cause is the communication gap which is there, which we are facing all these problems today. And if you see, all of us put our hands on our heart and say that That however good you have done in the practice, however good a clinician you are, it are not going to be attacked in the future or not going to swing for any damages. I think no one, in today's era, I tell all my students, our generation, action against us, legal action against us, was absolutely very rare. But henceforth in the future for you, face it, and that is what to try to do what is going to happen in the future. And that is for what I'm sitting over here to talk to you today. So the patient views you as a clinician, as a savior, sometimes as a God, which I hope you are not. And traditionally, then of course, as a magician and ultimately as a devil. So all depends on what stage of the treatment you are, the patient is there. Depending on that particular field that is there. And angry patient, disgruntled patient, patient who feels that you have not done enough for him, who is going to be the one who will sue you. Yeah, IMA has got the statistics which have been put up that almost 82% of us from some way or the other, maybe physical, verbal, whatever we are, we feel the pressure that we are the reaction against us by the patients. And these statistics have been there in the public domain for long. And this is what we are trying to avoid, especially whatever the assaults are taking place, be it physical or overall or whatever it is. And this is not only for India. All over the world, if you see the statistics which have been put up, all over the world, there have been assaults on the medical establishments and the medical personnel. So this is not an endemic aspect, it is a pandemic aspect as far as the doctor-patient relationship is concerned. So first we have to identify what are the venues which primarily where these assaults take place. And as all of us are aware, emergency surgery, psychiatric surgeries are on the top of wherever, especially the casualty departments of the hospitals. They are the one where we see the maximum of either verbal or physical assaults being done on the personnel, medical personnel, or the institutions. And what are the causes of this violence? So if you see, number one is the poor image today of the doctors over the years. As I said, my father was a doctor. I still remember he was a practitioner. A patient came with a small child who was suffering with fever for 2 3 days. The wife and the husband were there. I was sitting there as a young student. And the father asked, why you don't the child why do you suffer? So the wife said, and the teacher, the father said that I do not have time. That time my father very much laughed. And then he walked back again. But that was good. Society and that has been purely created by the media because we never talks about the 100 good things that we have done. But that one mistake is where it comes on the front page of all the local papers. So this is what is happening. And of course, the second aspect is the lack of empowered patients and relatives, which I've been given the subject to talk about today. Then all of it, right, the long hours, the communications, lack of faith with the judiciary, therefore the patients and the relatives want to take it the doctor establishments and the cost of health that is going to be there. So, if you analyze where the problem starts, I think which also Dr. Singh so beautifully has put up is the excessive waiting time. May it be the excessive waiting time for getting admission, getting treatment, or for the discharge also. I work in a corporate hospital also, and invariably my patients after discharge when they come for follow-up, the first thing they tell me is, doctor, you will be discharged at 10 o'clock in the morning, and I will be discharged at 6 o'clock in the evening. And this is something which irritates the patients. And with that, if they feel that the bill is inflated, that compounds the problem. I was a jury in CII just about 20 days back. And the first prize was given to the hospital when the indications of how we increase the discharge time of the patients. We have done it. And that is also because that technology helps to do that. And definitely we should understand that. Then, of course, unrealistic expectations, poor understanding of what the treatment is, and that is because we have not communicated enough with the patients of what exactly is wrong and why things have gone wrong. And communication skills of not only the doctors, but even the staff, that is the nursing staff, the ward boys who are there, even their communication skill is what I think we should be trained, because that also makes a huge difference. Then inadequate staff, long working hours, there is no response whenever the patient presses the bell. That could also be the cause. And this is not only in India. There was a beautiful survey done in the US, and there also, if you see, 81% said that immediate attention of the reception was why they are angry with the institution is because they 81% felt that they have not given on time recognition and if you see, all of us think that a big hospital, a corporate hospital, things are much less. If you see, the last is the state of the equipment and the hospitals, which comes last. So patients want to be treated as human beings first, and then of course everything comes after that. So what has happened over the years? What has changed? So at one time, even the doctor-patient relationship itself has changed. Today we are looking at mutuality and more going towards the consumer. So what do you mean by that? In mutuality, before this, whatever we were treating, it was paternalistic. That means the doctor used to say, this is wrong with you, this is your treatment. The patient had no say in that and accepted whatever the doctor said. Gone are those days, patients themselves are now empowered, especially in the internet. So this means that it should be mutuality, that means we should have equal rights in the treatment or management of the patient. That especially what is happening in the world is the consumerism, and that is what I think Dr. Guruvela, someone said in the morning, that I pay for your service, so I should get the best of service out of you. This is what slowly coming as far as the doctor-patient relationship is concerned, and therefore things are changing. So what happens when, why are we talking about all these things? Why are we bothered about what these violent reactions or choice are there? Because it completely changes the mindset of the doctor. There is depression, insomnia, post-traumatic stress. Let me tell you, I have my colleagues, my classmates who are there. After almost 25 years of practice, have given up their practice because of these assaults. And they have, of course, since they are intelligent, all of us are from top of the society, they have done very well in some other fields like finance and everything. But four of them will give the survey and medical practice, and this is because of all these problems that is there. And then, of course, defensive medicine. So this is almost like a circle which is going on. Defensive medicine, cost increases, other patients are not happy. Against the assaults are there, against the defensive medicine comes into place. Investigations are being done. So ultimately, the loser is going to be the patient himself because of these problems. So we have to recognize that violence against medical practitioners is never ever acceptable anywhere. How do we do that? Empowering patients, relatives, caregivers is an important aspect of healthcare. It is a process. What do you mean by empowering? It is a process that involves engaging patients, families, and caregivers to increase care delivery, efficiency, outcomes, patient experience, and reduce healthcare costs and violence in the healthcare. That means the patients, the relatives, and their caregivers have to be part and parcel of managing the patient along the healthcare givers. So that is what we call as empowering. So what requires to be done to empower the patients and the relatives? So respecting, not only that, but because if you empower them, they start respecting the healthcare workers and the challenges that the healthcare workers, because you speak to them very frankly of what could be the complications, what are the problems of this. So when they understand all that, they will understand even how difficult it is for us to manage these patients, especially in an ICU situation or in a casualty situation, etc. So empowering patients and the families to become more informed and more involved in the care. So as I said, from the paternalistic, the mutuality is the best way in today's era, where both of us take care that we talk to each other and become involved in the caring of that particular patient. And communication, as everyone has been saying right from the first speaker, is one of the best ways of trying to avoid these assaults. Expression of the preferences, the patient's preferences also to be taken. So you cannot say, this is your problem, this is your treatment. No. The patient has got a right to also express his preference for what type of treatment, then the expectations and needs of the patients and the decision making, of course, where the patient becomes part and parcel of decision making of his management. What can be done? Cultivate patient-centered partnership. Again, this is mutuality. Patient centered, that means the patient is the center of that circle of whatever as far as the patient is concerned. Patient desires to be known as a human being, and the patient to talk. Let him talk. And at this slide, I will tell you where we are going wrong. Not only that, we have to take, as you know, mental health is becoming a big issue. Everybody is talking about mental health. We have to take into consideration the psychosocial issues of the patient also. So, patient is not a machine. That something is wrong. The gallbladder stone is there, something is wrong, remove the gallbladder. No. You have to take everything else also. Is the patient ready for the surgery? How is it going to be in the post-operative, etc., etc. And if you do that, definitely even the patient will follow exactly what the doctor is saying so that the treatment also becomes successful and the dissatisfaction of the patient reduces. One thing we have to remember in today's era is that when the patient comes to you, it is the experts. When I say that, we are the experts as far as diagnosing what the patient has got and managing him, but the patient is the expert in what he is and what he is suffering with. So it is only when these two come together that you can give the best service to the patients. So communication skills, everybody has been talking, and we have seen you may be the best of clinicians, the best of the person, the gold medalist, but if you cannot communicate properly with your patients, it's going to be very difficult to satisfy all your patients 100%. And the practitioner's failure to directly and accurately discuss the realities of the disease process and a healthcare treatment regimen, the end result is often confusion at the best and anger at the worst. And this is where this causes a lot of these, assaults and a lot of these problems, litigations and everything against the doctors. So where did we go wrong? Poor communications means what? And this is a study this is all presentation that I'm doing is already the study has been there. What do we say? Doctors do more talking than the patients. That means 72% of the doctors in the opening statement, the first thing that we are taught is what is wrong with you, and you must listen completely to what the complaints of the patient. But we have found that 72% of the doctors, within 23 seconds, have interrupted what the patient is saying. That means you are not heard through all the problems that the patient has, some problems that the patient has. And all they said that if you had given 6 more seconds to the patient would have been a satisfied patient. So these are the studies which have been done. Doctors often ignore the patient's emotional health. We don't take, as I said, psychosocial health is also very, very important in today's era when we are treating the patients. Doctor estimate the amount of information patient wants and overestimate how much they actually do. So in a 20-minute OPD session, when the doctor was asked how much time did you give the patient, he said I gave 9 minutes, but the actual time given by him was 1 minute. So this is a vast difference where our perception that what we are talking with the patient is concerned and what the actual time that we give the patient, there is a vast difference, and these are all studies which have been made. And of course, doctors who cannot communicate, obviously the litigations are going to be much more in the future also. Communication is one part. Informed consent is another aspect which is very, very important, especially 10 years in the council. I am saying that majority of complaints which are there because informed consent is not taken. It's called the consent or the express consent for whatever procedures we want to whatever this, surgeries that are doing. But slowly, I think in corporate hospitals we are already doing that. We are taking what is called an informed consent, which is a complete, it's a big one talk itself. So patient requires complete information about his condition and his treatment. Not only that, even with that treatment, if there are any complications going to take place, it is the patient's right to know all these things. This is what is called an informed consent. If you tell all these details, when there is a complication, the patient and the relative know that they have been already about these complications. So nothing is wrong with the treatment of the doctor, but this is part and parcel of the treatment process itself. Then, of course, video recording is another aspect which is there. which must be, I think everybody of us slowly should adopt, because you can, whatever you talk with your patient, the conversation, you may not be able to write it down, but again, you can become a good but of course, that again relates to the permission of the patient before you record the consent. This is another very, very important aspect. That majority of us don't do in our hospital. And that is having a patient redressal system in the hospital itself. See, whenever there is a reaction from a patient, the first thing he wants to do is that I have been wrong and I require some forum which listens to what wrong has been done to me. If they do not get that, of course, then they go into all these internal and extra constitutional aspects of assault and etc. and on the patient. So if you have a proper redressal system in the hospital where the committee hears what the patient has said, the committee investigates with the treatment column, they make the doctor, and this is what I have seen even in the council, when they come, when the patients come complaining, you have the patient sitting there, the doctor sitting there, and then the patient, why have we complained against this doctor? And of course, the doctor has given this why the treatment and everything. The first thing that the patient said, if the doctor does all this, what he is telling in front of the council, we will never complain against this doctor. We have known what went wrong, because not the management of the doctor. So in this redressal system itself, if you have in the institution, definitely not only the assaults will reduce, but even the patients going to all these consumer programs, going to all these councils and everything, what we have in every institution. Of course, this redressal system, now there are books on that also, how to form the redressal system, what committee, what they should do, the hearing and everything, so that the patient is ultimately satisfied with whatever is said. So conclusion is, violence against healthcare is a global thing. Attacks against healthcare are increasing every day. So lack of empathic patients, readiness and fairness is definitely a major issue which we are discussing today, and I hope that tomorrow we will solve all these problems. Then medical jousting is something that it was touched upon by the speaker in the morning also. It is we ourselves, when I say we, our members, there's something wrong. So be very careful of, as far as that, we call that as medical jousting when we talk about that. So as Robert Owen said, God and the doctor, we alike also, but only when there is danger. They don't mean God not doing the doctor when they are absolutely all right. So once it is over, I like repeated, that is completely happen. And the doctor is everything. So thank you very much for having me.
So thank you, Dr. Putre, for this wonderful session. And I think one thing that Dr. Putre made it very clear is that you have to empower patients. You have to somehow bring to the concept of mutuality. And we at CAHO, the Consortium of Accredited Healthcare Organizations, as an organization, we have started some initiatives, and I invite Hospital Board of India and other organizations to join us so that we speak in the same language. And that is that every hospital should start having a patient advisory councils. These are patients and family advisory councils, absolutely in vogue in the Western countries. But as a structure to get the voice of the patient on the center stage, we must start having a patient advisory council. We have come out with a white paper as to how to form it, how many members, how to select, what kind of training to be given on it. So I invite everybody to join, and so that we make it clear that every hospital should have a patient advisory council. Same way, let us also get very familiar to the concepts of PROM and PRIM, patient-reported outcome measures and patient-reported experience measures. Now, these are also terminologies which clinicians need to know. Somehow, only the quality managers knowing it is not going to work. So, for example, how are you saying that how much of your knee replacement surgery, somebody will say, oh, we have 99% kind of a outcome, etc. That is how you are reporting. But there is something known as a patient-reported outcome measures, which will have much more relevance even to you to understand that what are the problems that are going to be there. And now to have the last one, which again, just like the first one, I would say the socio-economic factors are again at the root of a lot of violence against this. And to do that, again, we have chosen absolutely, yeah, I think almost Kapil Dev or Ravinder Sehwag combined, Dr. Ashokan, who was the chairman of the Hospital Board of India. He was the Secretary General of IMA. He is the President-elect of IMA. So, sir, I can't keep on.
Stadium is yours.
Stadium is yours.
Next year. Okay. Not yeah. Model in the medical profession and healthcare industry. I will give Secretary Dr. Shetty. Let me dedicate this conference. Missionaries of this conference, Dr. Vinay Agrawal and Dr. Alexander Thomas. The purpose of this conference is to bring together the medical professions, the industry and other organizations. And we talk with a sense of purpose. We have a single voice. So this conference should be dedicated to missionaries of medical profession. And sugar in milk. That's the template of the thing. And my dear beloved Sharad Agrawal and our General Secretary General, they have seen that it is happening here. And thanks all of you. My difficulty is being juxtaposed with giants, and we are given a topic which is very abstract. And, to an audience, which consists from captains of industry, leadership, clinicians, young doctors, and medical students. I think then the best way to do is to keep it simple. To keep it simple in the escape mechanism for me, I have only 4 slides, so I think you can all relax. The first thing is, to separate socio-economic factors. This is a general because I want to be ambivalent words. Social causes are different from economic causes. Social causes are very difficult to move. They are not within our power to change. Economic factors to some extent, advocacy work. So social causes, yes, already it has been spoken about the consumerist culture. The society has changed. It's a paradigm shift. I have money, I will buy. So first that. And they are all go-getters. And they don't accept any longer no for an answer. The perceived image of hospitals and doctors by the society, very unfair, but not untrue. Because the majority is not like that. But not untrue, because as Dr. Talwar mentioned, there exists a forwarding commission. There exists a lab commission. There exists a scan commission. There exists incentives. They are not disappeared. The former Prime Minister Manmohan Singh mentioned to medical professionals that get out of this. It was so painful that a Prime Minister took note of this. So the perceived image is not untrue, but it is unfair. I will accept that it's unfair because it's not separating ethically practicing doctors, clinics, and hospitals away from the chaff. The expectations, already it has been said about the expectations. In my own state, Kerala, the Most of the patients are 85 or 88 and will not understand the intensity with which the relatives bring them, the intensity, the commitment, and the passion with which they bring them. They are so serious about the patients or the medical profession or even hospitals. It's lost on them. They don't have that information at all. So it's so difficult of this the burden of expectations is on the hospitals as well as the medical profession to prove themselves in every case. It's not possible. It's not possible. You cannot, save every patient. The information and knowledge, basically they are different. The society doesn't understand. Information you can get in plenty. It creates only frustration, anxiety, knowledge. You need to be there. You need to live that. You need to imbibe that medical practice. They read because that information is available. But information is not knowledge. But they think information is empowerment. Not at all. Information is never as a matter of fact, I will go one step further. That ignorance may even be bliss. The fourth one, violence-prone society. The fourth one, the violence-prone society. We have moved as a nation from a freedom struggle of non-violence. We have moved as a nation. The political and other atmospheres and other dimensions of the society have understood and they use violence as a tool. Violence is acceptable. The resistance with which our own violence laws are faced by the media and the society is so much debated. It's so much accepted. So the violence being accepted as a tool to change things is not wrong, but because it's aligned to our culture. So our culture has moved, our society has moved, we have moved as a nation. Economic causes, I said this is to some extent modifiable, to some extent. Withdrawal of the government from healthcare sector. I know that this is a very strong statement. But I need to say that. Because we are basically a poor nation. 92% of Indians earn only $2 per day. And amongst these, 28% of the population is below poverty line, and that is 28.5 rupees. Very conveniently decided by the amendment that the international poverty line is $1.75. And amongst these 40% are multidimensional poverty. So we are a poor nation. First, we need to accept that our approach to healthcare has to be in a similar way. The gap between the rich and the poor are increasing day by day. Crores of Indians go below poverty line every year because of catastrophic healthcare costs. That's the dimension of the problem we are facing. Still, I will be kind to the government on one is it's a population which is growing out of we were 1 billion. We are 1.4 billion. 1.4 billion consumes most of the countries. So that's the dimension of the problem our own government has. So I think we give that benefit of doubt. But it's also lost from 1 trillion to 3 trillion we have moved. This is the trend in the healthcare expenditure. Updated only up to 2008. The current data of GDP is slightly different. But if you see it across the board, the second line, The total GDP, that is private sector, public sector, has been only around 3 to 4% of the GDP. So that means for years together, it has stagnated in 1.1% of GDP by all governments, central government, state government. The rest time is burden falls on the private sector. So that's a extraordinary situation where the government has lost the leadership. Where is the leadership? So that's why I am constrained to say government has withdrawn from the healthcare sector. The voluntary health insurance is only around 4% as of 2018. So going again to the missing missed opportunities. The first missed opportunity, the dilemma between primary care and vertical health program. This is the program. Yes, you work on care on one planning for 5 years. The next 5 years is for vertical program. This dilemma, lack of vision in integrating social determinants in healthcare. How can social determinants be separated from healthcare? There was a high-level expert group of 12th five-year plan led by Dr. Srinath Reddy, which proposed universal healthcare, moving it away from the universal insurance coverage. There is a difference. It is universal health care. The industry has moved into universal health coverage. That's the power they have. National health package in inpatient and outpatient by the government with strategic purchase from contracted private industry, private hospital. This was their design for universal health care. They eliminated private health insurance. The next day, World Bank came all the way running to New Delhi. This was a revolutionary document we had. Never got implemented. Never saw the light. It's a revolutionary document after so many years. This high-level expert group of 12th planning commission still suitable for the country. Ayushman Bharat. It's a faint shadow of our expectations. Faint shadow of our expectations. You know why? One, deficit financing to the level of only 10% of what is needed. Even that, using Ayushman Bharat for funding government hospitals. Government hospitals you can fund directly. Why would you fund government hospitals through insurance companies? The purpose for strategic purchasing from private sector never realized. The middle players siphon out 15% of the budget of Ayushman Bharat. What for? What for? Is it a small sum? I take the missing middle. India has 3 sectors. Government sector, for-profit sector, and a sector because of the medical profession is also hospital entrepreneurs. This disappeared in United States in 19th century, in Europe in 20th century, in Southeast Asia currently, we are the only nations, perhaps Pakistan, Bangladesh, South Asia, where we have hospitals run by doctors, nursing homes run by doctors. This is disappearing. Anything good or anything bad in this country starts with Kerala. COVID came to India through Kerala. Hospital violence started in the early 90s in Kerala. But it's also good. IMA or MMR, you say that Kerala is the thing. So this is the evidence which is happening. You look at 1995, the number of hospitals, it was around 2000. Today, we don't have a current statistics, but IMA has statistics because we run the biomedical based project. Today, you cannot get a license for hospital without IMA giving clearance. We have around 1,000 hospitals. We lost around 1,000 hospitals. Now look at the number of beds. In 95, the number of beds was 70,000 and now it is around that 70,000. So the average number of bed hospital was 34 in 1995. Today is 68. What does it show? Small and medium hospitals have disappeared. Now the for-profit hospitals have displaced small and medium hospitals. Where are the doctors? Doctors have receded. They are not there. This is what is happening in Kerala. I am sure the nation is going to follow this only. This model is going there. So this is the missing middle, which I have said missing middle. The missing middle too. This is an unimaginary initiative of the Niti Aayog. No, they don't have options. They cannot give government leadership in health. So these 70% are going to be left to the wolves of private health industry. Very unfair. There is a document by Niti Aayog on missing middle. This middle class, what is the direction that it is being taken? The country is being, are you not going towards the model of United States? 16% of GDP is spent on an unsatisfactory healthcare. Are we not going in the same way? And the last one is that, it's all industries now. It's a healthcare industry. It's an insurance industry. It's a hospitality industry inside the healthcare industry. And again, a pharma industry. Where is the profession? The profession has actually receded. We have, left that space. We are not the leaders of healthcare any longer. So I think, to conclude, it's a consumerist, information-driven society where violence is an acceptable tool. 2, loss of government leadership. It's a captainless ship. It's just floating wild in the ocean. We do not know where it will land. Industrialization of healthcare. The profession's portion in all these is receding. And a receding, defensive, helpless, and fragmented medical profession. So challenge to the profession in this socio milieu is to understand the social milieu that it is changing and the fast moving technologies. As the chairman said, there is no use fighting the technologies. But there is something which is in our hand which can stabilize at least the medical profession. That is what? It's the art of medicine and the etiquette. It's the best of human civilization. Is art of medicine and etiquette. And it doesn't change like ethics. Ethics changes with time and space. But etiquette, it does never change. Art of medicine, it does never change. So what we can do is that stick on to these very orthodox qualities of medical profession, and I think will be taken care of. Thank you so much.
Thank you, Dr. Ashokan, for such a hard-hitting, absolutely wonderful session. And I must say that this is a topic probably which will require 1 day or 2 days deliberations on its own. It's not easy to kind of sum it up or come out with, but certain facts are very clear. As a society, we have moved from taking the medical professionals from demigods to the devil. That journey is becoming very fast. And why is that journey becoming fast? One, of course, there are a lot of deliberations, etc., have happened to understand that why is that happening? But one of the things is that today, an unfavorable outcome is a huge problem right from a very small child. You look at a child, if he is not getting something of his or her own liking, the kind of reaction, and the parents, how they are indulging into providing them, or how they are tackling that unfavorable outcome. So one is that there is a cross unacceptance of unfavorable outcome even from the medical professionals, and it is compounded by the portrayal by the media, because every time some cause will be attributed to that unfavorable outcome. And second, the economic factors are huge, like what you have very beautifully said, that it's like I don't have enough money in my pocket, but I am dreaming of the kind of care that we get in the United States. And the fact is that in my own lifetime, about 40, 45 years back, people used to be carried to United States for a cardiac bypass surgery. Today, the bypass surgery is being done in every mufassil town, every tier 2, tier 3 towns, we are doing that. So a lot of progress has been made. And we are doing those surgeries at the cost about 4,000, 5,000 US dollars as compared to 50, 60 or 80,000 US dollars. So somewhere along the line, one has to see that what these private hospitals, corporate hospitals, what they have brought in as a part of progress in the medical profession, and how the society, which was not able to afford some of those payments, they have not been able to kind of keep pace with that kind of a delivery of healthcare. And the government, in order to provide the same services, is trying to reimburse in the form of the various schemes, whether it is Ayushman Bharat or CGHS, with various studies done, even at the cost of 50% of the cost of the procedure is being reimbursed. And with the result that the balance payment has to be taken out from the cash paying patients. So that is causing a huge amount of, I would say, socio-economic problems. But one thing for sure, overall, I must say, as far as the healthcare delivery is concerned, it is on a very positive kind of a outlook. Technology today is going to change a lot of that particular things that what we are talking about. But congratulations, I would say, and I'll request now my co-chair to please sum up the session.
Thank you, sir. It's very difficult once Kapil Dev spoken. What's more important is that the times have changed. I belong to a family of 3 generations of doctors. The noble profession has now actually converted to a profession. So people see us like a profession. And the problem is the same thing. Ayushman Bharat is there. CGHS treatments are there. So these are already always compared to people which is given in a private hospital. Other thing is the documentation. We should have documentation done. Complications do happen once we are doing surgeries on elderly patients because the life expectancy has already increased. We should be able to document the complications. That is what is more important. And be communicative with the patients, tell them this has happened, chances are this, and the patient might have this outcome after that. One most important thing is we should be friend to our friends. We get patients who have complications done in other places. They are referred to big capital hospitals. And the first thing which is presented to them is that there's a complication which has been done by a specific person. So we should be friends to our friends. That is going to prevent the violence from happening. Thank you so much.
Our sincere gratitudes to our respected speakers, Dr. Sanjeev Singh sir, Dr. Shiv Kumar Rutre sir, Dr. R.V. Ashokan sir, and esteemed chairpersons, Dr. Vijay Agrawal, Dr. Chitesh Bali sir. And we kindly, sincerely request you to collect your mementos from there. And I call for the further proceedings, Dr. Shan.
We move on to the next technical session. That is session number 2, preventive and mitigation strategies. In the words of Albert Einstein, it would mean that we are trying to be both clever and wise, since he has said a clever person solves a problem, a wise person avoids it. And for this session, we have the chairperson, Dr. Babatosh Biswas, President, HPI. Dr. Babatosh Biswas, the chairperson, co-chair, Dr. A. Lingaya, Vice President, Anbai. We have two speakers, Dr. Atul Kochar, the CEO of NADH, speaking on effective communication and patient education, and Dr. M.I. Sahadullah, Chairman and Managing Director, KIMS Health. An important announcement, please. We have already overshot the time by 18 minutes, and I would earnestly request the subsequent chairpersons to ensure that the session concludes within the allotted time. Please. And the speakers are requested to adhere to the allotted time of 3 minutes, 15 minutes, and 3 minutes to the chairperson and 2 minutes to the co-chairperson. Thank you very much, and over to Dr. Babatosh.
Very good morning. We have been listening to very interesting topics. The subject is very important, violence against hospitals and healthcare professionals. What we have learned by this time, that this needs a lot of thought and a lot of effective measures by every one of us, every hospital, every physician, and all concerned. In this session, we are going to discuss about preventive and mitigating strategies. There is no doubt that the violence in healthcare sector will keep happening. Even with all positive thoughts, you can presume there may be less aggressive, but so long human being existing there, violence will continue to be there. But we want to reduce it. We want to make it a minimal acceptable. We have to discuss in this session regarding the preventive and mitigating strategies. So, a couple of words I want to add before our learned speakers talk on the subject availability. We have already spoken. Effective communication is major. It needs to be narrated properly. Now, the speakers have spoken in adequate another word which has been uttered during earlier session, that science and arts and both are measures. Science will know, but science is growing every day. Healthcare and things, industrialization, everything is growing. Art is coming down. There has to be balance between science and art. That is a essential thing to discuss now. And our concern with patient and empathy, there's a fundamental thing which we all know, but definitely there is some bridge, there's some problem happens. Obviously, positive therapy. Every good treatment, every modern gadgets, modern medicine, modern hospital needs cost. What of people cannot afford in spite of private or government healthcare system, but treatment has to be given to everybody. So people get irritated. They don't have limitation in other sources they have. Either they don't have enough money, or they are not properly taken care of by concerned people in the healthcare system, or they are coming late, or the society is violent, as we discussed by Dr. Ashokan earlier. So all these factors finally end in hospital, where people come under compulsion. People go to hospitals by selection, by choice. In hospital, they come under compulsion. They have to accept the expenditure and pain of staying in hospital. Finally, during discharge, everything is settled. But communicating by doctor that he is going to discharge today at 8 a.m. and he is getting final settlement around 6 p.m. in the morning. So all these factors contribute to irritability and maybe need us for health balance. So in this session, two different subjects were dealt by two very learned speakers, and the effective communication and patient education to be discovered by Dr. Kuchar
from this introduction of the and he is the professor of gynecology, his own personality. Another important subject, robust governance framework that will be built my very best friend and learned person to the Shadula. And this is the president of the Kerala chapter and the chairman managing director of KIMS. So these two learned speakers will do justice to the related subjects now. I welcome Dr. Kuchanam to the subject.
Thank you so much, Rangan sir. Good morning to all of you illustrious people. And I'm so grateful to IMA leadership, Dr. Yani, Dr. Vinay Agarwal, all the presidents, all the past presidents for giving me this wonderful opportunity to be a small part. Coming in after Ashokan is no small feat. Actually, that itself is a big thing. And he beautifully outlined all the root cause analysis of what is the genesis of violence and where the society is being headed. I think the end where he left off was what we could do, how we could set our own house in order wherever it matters, is what I'm going to take you through over the next 15, 20 odd minutes. So, effective communication in patient education is my brief, and the basic title of this session is preventive. And as chairman sir very astutely pointed out, what could be the main preventive and mitigating strategies? Of course, the root cause Dr. Ashokan sir outlined is a very humongous thing. There are hundreds of causes, millions of variables, and each case is gray. It's not black and white. It's not even 50 shades of gray. These are million shades of gray. And anything which could trigger violence, one of the most important mitigating and preventive strategy is communication. I need not go again into the statistics, which states that over 75% of doctors in India and possibly world over are subject to abuse during their professional career. That's a big number. And we are not speaking about physical violence, it could be emotional violence, verbal abuse, all sorts of abuse. Violence against doctors is everywhere. Not a week goes by where we are not exposed to a news item which says that some of our colleagues have been mishandled, or even youngsters who are just starting out have been grossly to the large extent. So this is a very real problem. In fact, the entire leadership of doctors in Delhi combined with IMA, they came together a few weeks back to create a Chalo Rajghat, which had its impact, but we need more such things. So that's the gravity of the situation. I'll not go into that. I'll only address a very small part, which has also been reported in the press, that now efforts are on to impart communications to the doctors. I do not mean to say or imply that doctors are not good or effective communicators. In fact, the erudite class they are, I certainly believe that majority of doctors know their mind, know how to convey, and are the topmost communicators across the country. But how, as Dr. Ashokan sir said, we could put our own house in order and improve on that art of medicine. That is the brief of this topic. And let's today see what is effective communication and how patient education very, very briefly can lead to prevention of violence in case that is. Well, a small part of root cause analysis just being limited to the communication arena, not going into the social ramifications, the diversity, the government spending, or any other aspect, is the common patient grievances which are always there. So there are n number of studies from consumer safety organizations, the patient for patient safety,
And these are not general. These are not general. That does not mean to, I do not mean to apply at all that all doctors are exposed to such grievances. Majority of our colleagues do very well. And that's why India is touted as the cradle of healthcare, the heal in India, heal by India, heal from India. They're all taking off so well. So chronic patient grievances, wherever it matters, is too little time for patients. Yes, doctor does not listen, doctor does not explain well, shows no sympathy, and neither understands the patient nor his family. So these are certain feedbacks received where a violence has been triggered, and that's the other side of the coin, which is the side of the violence perpetrator. So how can we handle that? Well, we truly believe that we are the saviors. Of course, we are, but the patient sometimes perceives us as paise chhal diye. It's a commercial society, it's a consumer society. So all those things are also a society which we live in, as was very beautifully outlined by Dr. Ashokan. I speak without malice, and I truly believe, I reiterate that majority of doctors are very effective and very astute communicators. It's only that we are trying to do what more can be done or could be done for our youngsters who are just starting out in the arena. So, n number of studies have been carried out. They are published in peer-reviewed literature. I am quoting one from 1984 by Beckman and Frankel, which has been quoted ad nauseum across literature in the medicine circles. The effect of physician behavior on the collection of data. This is a study which was conducted in 1984, nearly 30 years back, and this outlined that a patient is interrupted. It takes about half a minute for a patient to convey their problems to the doctor, while 18 seconds is the cutoff. This study found in 74 average consultations across state of United States, that 18 seconds cutoff where a doctor interrupted the patient in describing or eliciting the history. The other corollary to that is in 2009, Norman conducted a study which found that 6 minutes is a time which takes an average doctor to come or arrive at a diagnosis. And in 79, Stewart et al. Found that 50% of patient complaints were not addressed in clinical encounters. So this is the basic thing. And frankly speaking, this is not a new problem. Starting from the 84, which found 18 seconds, 99 in 1999, Marvin conducted the same methodology, repeated that after 15 years, and found that patients were interrupted after 23 seconds. Rhodes in 2001 found that patients were interrupted after 12 seconds, while in 2018, the last line on the thing, that patients were now also interrupted by the telephone of the physicians. So these are also a reality. So while we totally agree that we are battling a huge problem, but the other side of the coin also reflects that somehow, somewhere, the interruptions are always there. And in case the patient is devoting adequate time to if the doctor is devoting adequate time to the patient, probably some of that time is going into inputting. So it's also a real case scenario where the doctor may be handling a patient, but majority of that time goes into inputting the data priorly for whatever reasons. It could be any reason for that matter. The same study replicated in 2018, and we do not have much data after that, possibly because COVID struck, from the Mayo Clinic, that patients are now being interrupted at 11 seconds. So that's also the crux of the problem. Somehow, somewhere, doctors are losing their patience in listening to the patients. So that's also very, very realistic. And it also, the same study found out that when a patient visits a doctor, it's not for one cause. So average number of concerns patients have range from 1.2, how the marginal is concerned is not known, but to 3.9 in both new and return visits. So thereby lies the grudge that patients are not satisfied because 54% of the patients go back and they somehow feel that all their concerns or questions are not being answered and the concerns are not being addressed. So that is also a very real scenario, which brings us to the fact that communication, which is a two-way communication, is very important to satisfy the patient and thereby prevent the violence which could be triggered because of lack of such intensity. So good communication is needed. We all know that to develop relationship, increase our knowledge, make our feelings and thoughts count, and find out about people and find out information. Information which could be just gathering the history, or it could be information which could be across anything. As a physician, in a routine manner, or as a healthcare staff in routine manner, we daily have to interact with not only patients and caregivers, but also with our colleagues, which are the nursing officer, the auxiliary staff, the administrator, the reporting research findings. That's also a written communication. Talking to the media or speaking to the media is also there. And of course, speaking to the public and the legislature, the executive is also an option. So communication is in medicine, various studies which are there in peer-reviewed journals have highlighted time and again the importance of effective communication between not only patients but also our colleagues and also our subordinates. And it's a foregone conclusion that effective communication improves patient satisfaction and health outcomes. So somehow, somewhere, clear directions, clear messaging saves lives. It reduces medication errors. It increases the tenets of patient safety and thereby increases the healthcare quality. It reduces the risk of complaint and medication also. And of course, it ultimately leads to higher level of satisfaction. Communication, on the other hand, also it's a foregone conclusion causes a lot of misunderstanding, hinders work and hinders our productivity. So, howsoever busy we are, in case we indulge or do not impart correct or complete information, then it leads to incorrect recommendations. Poor patient experience can lead to wrong diagnosis and somehow irregular follow-ups also. So it's very important that effective communication should ensure it's required to ensure good working relationship, increase patient satisfaction, and reduce uncertainty besides the medical legal aspects. Fortunately for us, as previously also we just heard, that technology is one area which is time again helping us and it's growing steadily. Dr. Vijay Agarwal sir very rightly pointed out that we have never had it so good. From starting from a simple SMS to remote monitoring to electronic records, the time here and now is totally backed by technology. And technology, please believe me, is the only bridge which can bridge this divide of provider versus providee. There will never be enough doctors as the population is growing, but technology is the only bridge which can help us effectively communicate to the next level. And the basis of effective communication is trust. All that trust deficit which has been increasing in the society for whatever reasons, if we have to bridge that trust, rebuild that trust, then communication is the only key to that. And effective communication, time and again, reduces malpractice crimes also and increase patient satisfaction also. So as was highlighted by Dr. Kshitij also, always keep the patient family members informed. So that's how you do it. Why you do it is not a question, but you have to do it, but do it in the optimal manner. The second part, which Dr. Again coming back to Dr. Asukan, he highlighted that listening is an art somehow which is going away. So Bhavan after that great he mentioned that if you listen to the patient well, your diagnosis is made. So that is the key. So it's always part of the effective communication that you should go beyond effective listening. You should go beyond listening. In fact, you should learn to not only listen, but to engage, observe, and in a nutshell, empathize with the patient. So listening is an active activity, while hearing is a passive activity. So active listening, mindful listening, deep listening, that is when you are there with the patient then and then. So that comprises the active part. So that also is an acquired, which they don't really teach you at medical college. But I truly again believe that everyone who's chosen medicine, whether it's a physician or a healthcare staff, majority of them are there for that empathy angle, which is already there, but somehow it's dulled by all that indifference or insensitivity or various other factors which are there. So listen to the patient. The biggest problem, as Stephen Covey said, in communication is that we do not listen to understand, we listen to reply. So somehow, somewhere, we also have to inculcate in our busy lives that and practice and build up on that active listening skills, which are a key core part of effective communications. Of course, there are many barriers to effective communication, starting from our personal attitudes to ignorance to human feelings, tiredness, stress, language, poor time management, and of course, the strenuous working environment. A typical public funded hospital doctors on an average OPD sees 100 to 150 patients a day, which no same colleague in other part of the world is even possible. But that's a reality. So how to work with all those existing scenarios as they stand today is to improve ourselves. That's what. The other core part of mitigation and prevention is effective proven strategies to educate patients. What we could do to educate patients so that the violence is not triggered is also a very important part. First is to use plain non-medical language. The more jargons we use, the more the chances of error, more the patient will assume things, more they will seek information but not knowledge from the Google, and they will go back with half information. That frustrates them. Teach people skill for self-management. So that's also a part of our duty. So somewhere we'll be failing partly if we do not impart the correct or give time. We could also show or draw pictures, use technology, use that interfaces which we have. And in fact, there is so much of authentic patient resource data which is available on IMA site, on professional body site, which has been generated with lots of simple storytelling manner. We must use robust patient education material and also integrate modern methods of patient medicine. We can use the teach-back method where we need to confirm from the patient whether they have heard clearly, and that's a proven strategy in the airline industry or army or air force or navy, where you have to repeat the orders so that everything is understood clearly, and nothing but the last line that we have to somehow spend more time with the patient. And just to allow me to sell NABH also, because NABH in the forefront has always built its standards around communication. Our first chapter, AAC, Access and Continuity of Care, always highlights communication. From handing over a patient to taking over a patient to passing on from movement from one ward to OPD to emergency to discharge, they've highlighted. All chapters are built around a matrix of patient safety and healthcare quality. Our chapter 4, patient rights and education, highlights all aspects of patient education and which are ingrained when the staff does same thing and again. It's a matter of atomic habits. Every time we do same thing and again, we keep improving and we keep raising the bar. So these two are very, very important chapters, and communication, care, compassion with empathy are always better. And all communication strategies will fail if, as Dr. Asokan, I'm coming back to him because he highlighted that, do not practice. If doctors do not practice compassion, are not humble, are not kind, and of course, they do not practice gratitude, because that's ultimately the art of medicine, which will all remain on paper and has to be cultivated. And communication is an active learning skill. I'm a fan of this book by Dr. Alex, and I'll request that this is a wonderful book which will be takes one physician or even a young colleagues across all aspects, how to break a bad news, how to things. And these are active learning skills which one must go again and again to delve into. And as seniors, it's our duty to impart to them. So, as on introspection, let's learn to communicate effectively, optimally. Let's learn to listen empathy patients, be kind, be humble, be grateful, and of course, remember that first, our main tenet, primum non perseverare, above all, do no harm. Thank you so much. Yeah. Thank you very much, Dr. Kochar. I just utter 4, 5 words, what he quoted very, very strongly. The doctors need to learn communication skills. They're definitely skillful, but it is a continuous learning process. Every day, doctors who learn the skill of communication. And there is definitely upgradation of technology, trust building, everything is there. But learning the art of listening is most important. And he has done justice and kept pace of what has been taught in this hall, what has been discussed. Dr. Ashokan has set the ball rolling. Being a person of quality from NIH, he has brought forward the idea of quality, the quality person that again is here, that quality is most important. And another thing that regarding communication, the book what is quoted about Dr. Alex, that is the Bible and Gita of all healthcare professions. With these words, I thank you again, and I request my great friend Dr. Shahidullah to discuss this subject. Thank you. My slides one. Dr. Lindemann. And ladies and gentlemen, it's a great pleasure to be here.
Your people,
This is not the one.
have you learned? Have you pen drive?
No, this is not the slides I have.
Okay. Have you
It's a violence against Shahidullah.
Do you have pen drive?
Hmm?
Do you have pen drive?
This is the one, yeah. Can you open it?
This one?
Yeah.
This one? No.
Is it? Okay. Go ahead. Good. That's not the one, but anyway, just open it and see whether it's mine. Very nicely, very in just. Yes, yeah.
This one? No.
Mine is the governance. Okay. This one. Violence
Do
in.
you have pen drive?
Okay. I have pen drive with the room. I
think you are not.
send it to Anthony, you know, so.
Sir, we have not yet received. We have not yet received. Sir.
Kripesh, what has happened? All right, it doesn't matter. With the slides. Secondly, I think I want to thank Dr. Gilbani, Dr. Agarwal, Dr. Alex, and participated in coming here, and then it's a great honor to address such a intelligent crowd of meetings in the healthcare. There's no doubt that we are at a stage modern healthcare delivery and advances are comparable in our engineering ecosystem. There is no doubt that quite a bit in patient safety. And there's no doubt that our quality systems are improved. Ethics are improving. And so healthcare, especially advances is going very well in the country. However, standardization is required and also governance framework has to be put in, and perhaps that will be the reason where you know, I'm trying to teach and share a few thoughts about it. And I think my slides may come, but technology is the most important thing now. Utilization is working, but often this happens. So I always try to get a hard copy, and so that this is very good. Oh, okay. Thank you very much, the support system. So, a lot had been spoken, and we are also in evolutionary stage of healthcare. The pressure that was about the healthcare industry.
Slides.
Which one is
Next.
this one?
This one's for
Go
previous
forward.
and. Yes.
Yeah. Okay, that's right. Yep, and we ourselves also ask for industry status for healthcare. We talk about universal healthcare and universal health coverage. And survived, you know, very efficiently, I should say, pandemic. And we set a lot of examples for the world. And so we are definitely in the vaccine stage. But do we have all that safety network and governance framework we need when we talk about our safety? So in the last conference, and we were talking about patient safety, and today we said something. It's nice to share and nice to understand that we're talking about healthcare worker safety and doctor safety. It's so important thing that at least it's a subject of national debate. Like the utilization came late to take care. This as thoughts that has come in late. I want to congratulate everybody and the good friend and president and that's the one to work with together and they have brought the big subject in and perhaps in that itself in a big way and the government and all the others started listening to it. This is our 2023. And, I'm sorry, it is painful and sad to know that Dr. Vandana has a very graduate and has been and so I brought to my hospital, which is about and that had and the guy was there and the secret was there and that we could console that family. This is not a coincidence. And in fact, Dr. Chauvin showed a lot of statistics there. And so I'm not going to ensure any of those. And because we spoke many things about communication. So I just touch upon the 7 issues. And we have a lot of cases in doctors or healthcare workers. We have not reported, and the communities and they do not really a reaction comes only something that published, and then that's it, the story after 2 or 3 days, like many things in our country is forgotten. And so we need to change that status in the place. Violence can be not necessarily physical, but it can is often physical. So it can be verbal, it can be vandalism, and so I don't want to, this better statistics have been shown, and so psychiatric emergency medicine, clinical care, we also see a lot of problems in our hospital. But the metros are better, bigger hospitals are safer because there's a lot of people supporting. When we come to individually managed hospitals or public headquarters hospitals or other private hospitals, standalone in the rural area, that's where actually the role of IMA should end up coming because that's where they need protection. I'm not going to go through that, but the violence is, happens in these areas. And, so, I just want to save time for you. Yes, I would very well elaborated by Atul. The MSP director and daily speculation and to an practice. Other than and our hospital. The communication of the doctors has to be with integrity and honesty, confidentiality. And this is very important. And we may have to follow that. And this is not taught. I can say a very small example. I mean, I was practicing in an American hospital. And a lady came and they wanted to have the plan, pregnancy test done. And we did test her and it was positive. And after 2 hours, the husband came to me and said that, yeah, my wife came earlier, can you give me the pregnancy result? And fortunately for me, I said, I don't think I can give you because unless your wife is with you, or my wife has expressed the consent. And so fortunately, I did not give. And so there was a lot of problem, and the wife, the husband had vasectomy, and the wife had pregnancy, and subsequently problems came up. So that much confidentiality has to be kept with our profession. It is challenging for us, but so truthfulness, honesty, integrity, confidentiality are the key words we always teach the membership students in the examination. And I think that is part and parcel of our profession. It is not just for the examination alone. I will not go into this because it has been very well elaborated by previous speakers. And just I'll pass by and come to. Okay, law enforcement. Yes, there's a little bit of governance. Law enforcement is very important, and we have a lot of laws. And most important is that the authorities do not offer really accept it or they make enough action. And, that is the police as well as with the enforcing authorities. And that's where actually IMA has contributed quite a bit in Kerala. And there is, in the red letters, it says that 50,000 INR and 3 years imprisonment. But more than that, it is a non-bailable offense. But none of these things, actions are taken against the violators. I think in the national level also, we had a lot of hue and cry bills have come, and my information is that still they have to find their way to be a law. So I think these are the areas where our governance in the national level and probably in our own hospitals have to do. Learning from the West, in our ecosystem of healthcare delivery, I do not think that we have much learning because our kind of structuring is quite different. So you know that Europe, UK, and Canada, the healthcare cost is borne by NHS, and the practice system is very efficient, and probably USA workers is through insurance and corporate or Medicare. So I think we are at least in Kerala. 64 to 70% is out of pocket, and that is where major issues come. And when the amount of money goes on increasing with the seriousness of the illness or the stay, duration of the stay in the hospital, suddenly that starts irritating them, and then trivial irritations come up in the hospital, and then they blow out and go into violence. So this is an area where the nation is dealing with. Private participation has to happen. Insurance may make some changes. So I think these are areas where we need to improve. This is the hospital where I'm working. And there are few things to do, which we will share with you. The clinical governance, we put it together as been told, as a partnership with the patient and the system of safety and quality, patient-centered, person-centered. So all that you are quite familiar with. Communication, I have been told that at least in the ICU and in the high-risk areas, at least 2 sessions of communication to the next of kin only. And we cannot address to a crowd, and therefore, we only address to the next of kin. I'm sure everybody has policies. We have policies on the prevention, and we call it health policies and procedures, and that's a reference, and that's what we actually tell and introduce all the new doctors who are coming, especially the postgraduates and a large number of students who are coming. National students who are coming. Okay, it's time. So security surveillance system has helped quite a bit. That systems, and we have a code white. If code white is called immediately, the PROs and all the people will be coming, and that would help us. And the strong team, if it goes further, the security will also be helping. Some of the other things, I will just go through fast. And we mentioned robust grievance redressal system. The one thing is the financial discussion. In all elective admissions, please address the financial discussion from the very beginning. so that they know at least their future know later on. They decline that they have been, but we documented and we told them know that this will be the approximate cost of procedure. And so that has helped quite a bit. That's one of the things we try. And the rest of the other thing I want to mention is about the medical board. And this probably even IMA can do that irrespective of the specialties, even in small hospitals. The medical boards have tremendously helped. So a number of specialists sit together, discuss serious cases, and involve the relatives as a group and tell them, this is what we think, this is our management plan, this is the cost. If you want to go anywhere else, please go. And that has helped. Nobody has gone, but they have accepted the treatment. And so medical boards are highly recommended. I'm sure most of your hospitals have that. Another thing which has helped that any patient in more than 15 days will be reviewed medically and will be, informed to their relatives. I just want to go to the last slide. The bell has gone. Just a takeaway. The framework should be a dynamic risk assessment and mitigation structure, which has been elaborated, and some of the examples I said. Identifying and taking care of, handle with care. And that is a very important part. And compassion and all that is talked about. Education and training of the staff and the newly coming doctors is very important. With the various signages and all that also should be educated. In safety, we should be investment should be budgeted, and our safety is important, and it should be definitely a budget element in all hospitals. Promoting public awareness, including various awareness programs, including the media, and finally, the safety of healthcare workers as a event. Not only it should be an incident report in the hospital, it should be incident report district level, state level, and national level. Then only, as Dr. Chauvin said, the statistics will come. People will understand the bigger picture of the whole thing, and the nation will have statistics to work on. And we must have a chance. I'll just conclude in saying that about a week ago, I had a patient, we had a patient who was admitted with the post abscess. It was treated well, and the patient was to be discharged, waiting for the discharge summary, and immediately patient had a pain in the right shoulder, 32-year-old lady, and she just died, in spite of all our attempts. So it was very difficult for the family to accept it, but the family accepted it, and we were wondering why they accepted it. And when we went into the details, and we understood that there are two other members of the family had similar earlier premature death, because some of these things can happen in the family due to cardiac abnormalities, and she had, but we did not ask that history. And probably someone mentioned there about the proper history taking, like William Osler said, patient is telling not the story to tell you the diagnosis, but we should listen. And from IMA point of view, even small center, a number of doctors get and have no opinion, talk to the patient about the seriousness of the situation. It will avoid conflicts between doctors, as well as it will really impress the patient that we are all together, we have done our best, or we are going to do our best. And this I have spoken to my presidents, and some of it are doing it. Thank you very much for patient listening. Jai Hind. Thank Dr. Sadullah. Thank you, Mr. Shadullah, for elaborating, discussing this issue. Let me point out a couple of points that he has highlighted that. uh, so every month there are 5 attacks, and in a consecutive 3 years period, there have been 200 attacks in Kerala, and the universal picture across the country, and probably in the entire globe. Let's point out laxity in law enforcement, and I'm confident that our friend Dr. Nandimat will discuss in his next talk. And couple of other things as pointed out, that alarm system, then security services, the financial discussion, the grievance redressal system, as well as mock drill. When these sort of incidents happen, what to do? These things, this couple of points are very important, especially mock drill. Everyone should have at least an idea if there is some attack, some violence, what to do. Thank you very much, Dr. Radhikaran. I request my co-chair, Dr. Lingaya, to give his briefing. Thank you to all of you. Thanks, Dr. Always, and sir, and the excellent the situation of our healthcare system. In a diverse population, corporate hospitals, something to value, but also to hospitals also. But in America, everywhere, some problems that also happening. So people are not everywhere. Violence is everywhere. Reasons. So all it communication is the best thing to avoid these things. Proper communication is the excellent. As Dr. Science mother-in-law type of hospitals. Yes. We have mother-in-law type of doctors with us. And they take the patient from enter to the hospital to discharge. And I have seen that after you, they also they invite for service after death also. So that type of Dr. Atul told, some of the doctors they are very and they are doing the communication. With doctors, our consultant about doctors' communication skills, but seeing counseling and some are very good communication, some are very financial communication, some are not good in professional communication. So we are supplementing them. Now this thing is second thing because communication a lot of people I'm a practical person. Lot of things are discussing things, conference discussions are going on, but what is the implementation? Implementation, my request. Age arrived there, there, and yesterday we had a Sabha ceremony that Aman called and I like that. We were discussing the subject to the school colleges, but it takes a long time. But age, unbiased, and the crowd and all put together the program for communication skills. In a medical college, we have to go voluntarily to the medical college, the communication skills, and then each hospital we have to do. And once you have some points for this thing, some points should be for communication skills subjects also. The people should attend such program of communication skills. That also we have to do that. So in this way, I think things will properly make aware to the people. And one more last point what I introduced, we have to invite young doctors, medical college students also into this program. So they should be aware about these things. So that is my request on it. And no, partner, they have to teach, not attend. You have to speak also. One or two people have to speak also. That is my thing. Thank you. I would like to thank the chairperson, co-chairperson, and the speakers. They are already behind schedule by 25 minutes, and the entire session can be comprehended in one single statement, as said by Robert Trujillo. Quote, as long as there is communication, everything can be solved. Unquote. Over to Dr. Vani.
Thank you, sir. After this brainstorming session, moving on to our next technical session 3, which is all about the legal and ethical perspectives. I feel immense pleasure to invite the chairpersons of the same session. I invite Dr. J.A. Jayalal, sir, who is the past National President, Indian Medical Association, co-chaired by Dr. Shrijit N. Kumar, sir, convener, IMA Action Committee. And we have 2 talks in this session. First talk is all about safeguarding from the medical legal issues by Professor O.V. Nandivat, sir, who is Professor of Law, NLSUI. Second talk is all about ethical issues by Dr. Shri Kumar Vasudevan, convener Ethics Committee, Indian Medical Association. So the dice is yours, sir.
Good morning. I'm sure it is unethical to spend between you and the legs. So we're not going to have much introductions here. We have the Linux speakers here. We're going to talk to us on the law and ethics. Law comes into force only when you make a mistake. After making a mistake, the law comes into effect. But when the system and make a mistake. So these are very sensitive things, and we have very channel speakers to talk to us on the medical legal issues out there. So I have the privilege of the safeguarding of medical legal issues. Professor Nandivat is from the Professor of Law at the National Institute. Thank you. And good afternoon to all of you, ladies and gentlemen. Probably I belong to the microscopic minority of the audience because I'm an academic lawyer. So my style of address, style of presentation, maybe you needed to adapt because it is going to be slightly different from what you have heard already. Well, I just would like to run you through a small slide. In about 30 seconds, I try to say how I'm going to concentrate on doctor-patient relationship and medical malpractice law among the various things which I have listed there. Because when I started my journey around 18 years back as a lawyer to look into this particular area, I was told, it is medical law. Means, we are only looking at the medical malpractice. That is, the doctor, when they are sued, what kind of a law is applied and how courts are going to react, how law is going to react, etc. That is what I was told. But a lot of water has flown down the bridge now. See, today, we don't call it as, medical law. We call it as a health law. All these are facets. But out of that, I would still like to concentrate, respecting the time, only to doctor-patient relationship. And please understand, whatever I'm going to speak, you can apply it to a growing violence or the tendency of violence against the doctors, or it is with regard to doctors being sued in the civil courts. Both ways you can, take it. Why doctors are increasingly sued? There is a, ongoing study with about 3 of my students. We are doing that. We are culling out a lot of information and trying to understand. And we have, categorized the tendency of doctor being made as butt of attack or being sued at 2 levels. One is a macro level and second one is micro level. And when I'm talking of macro level, it, is some kind of an environmental change where the doctors are today made to work. These are the 4 very important points we could be able to appreciate. The first one is the changed doctor-patient relationship Much is being, talked about that by the previous, speakers. But ladies and gentlemen, I would say, what strikes to you when I say the doctor-patient relationship has over a period of time undergone a sea change? It is trust deficit. Somehow, the patient doesn't trust the doctor with whom he is interacting, with whom he is getting treated. That is what has diminished the nature of fiduciary character, which was earlier considered to be the DNA of doctor-patient relationship. The second one is corporatization and commercialization of healthcare delivery structures. Again, lot has been said. I don't want to talk much about that. Enhanced awareness and easy access to tribunals. This is one thing I was keenly observing is not being touched, so I would take about 30 seconds explaining it to you. The first one is, please understand the awareness about the law, awareness about my rights had completely, transformed over a period of time. So every patient who is coming to you is more right-oriented rather than anything else. And that is why when we are talking of litigation, we are becoming more and more a litigious society, not only with regard to doctor-patient relationship, otherwise as well. So don't really consider you are the only one, but everywhere this tendency of getting, sued or being sued, etc. is increased. And easy access to the tribunals. So when IMA versus VP Shanta was decided way back, the Supreme Court clearly said the doctors do come under the Consumer Protection Act. That was the game changer. So if I go to the tribunal, I have greatest advantages. Two I would like to highlight. Ladies and gentlemen, the first one is, if I go to the civil court, roughly from 7 to 10%, I have to shell out as what is called as a court fee. So if I'm claiming 1 crore of rupees, how much I have to pay? Around 7 to 10%. If you calculate that, I have to pay from my pocket to have myself heard. And it doesn't depend upon the outcome of the case. But here, if I go to the so-called consumer court, as they are popularly referred to, technically the correct expression is consumer commission, then I need not have to really take that kind of a, financial stake. See, it is easy access. The new consumer protection law further goes one step ahead and it says, it has eased down on jurisdictional clause also. So I may get the treatment here, go back to my hometown and sue. I can, take a treatment from somewhere and whichever is the most convenient forum, I can sue the doctor or the hospital there. So this kind of ease, because the whole idea of Consumer Protection Act, it doesn't only address easing the access to the patient, but it is overall talking about the consumer. So more and more liberty and access to the tribunal has increased. We calculated, we thought we would write it as, this is a project which we are going to publish. We are going to publish it as an editorial on Indian Journal of Ethics. That's why we said the first we will try to calculate and authoritatively state how much of, let us say, transformation has gone in. See, if you take 59, that was the first ever case reaching to the Supreme Court on medical negligence. There was only one case in 59, and today you have nearly 2,500 litigations lodged against the doctors. So there is so much of, let's say, litigation that has increased. It has got something to do with enhanced awareness and access to the tribunal. And erosion of autonomy of the doctors, because you are part of so-called corporate culture, which drives, towards the profit, but the doctors are alone expected to be delivering their services ethically. There is a conflict inherent in it. There is one more point I would like to just throw open. Look, for me as a lawyer to practice, I'm using only my brain. But a doctor to practice, he is dependent upon two more things. One is pharma industry, because without prescribing medicine, you cannot practice. And without devices, you cannot so-called practice or profess evidence-based medicine. And then comes your skill. Out of these three, two-thirds are recognized as industries. Pharma is an industry and device is also an industry. And they tend to push towards profit maximization. Only you are asked in a conflicting kind of a dilemma situation that you got to be ethical. Is it going to happen? This is a micro level issue which requires to be extensively debated and an answer to be found out. Otherwise, you will not have an environmental change, but you are pushing and nudging the doctor to be ethical. It is never going to happen. The second one is, these are some of the insights which we have developed. One is training and capacity enhancement. See, but when I'm talking of training and capacity enhancement, please, before that, I wanted to talk what makes a patient a disgruntled one. How did we try to? We took 300 judgments, 300 cases, which had reached National Health, Commission. And we started pulling out the data and we started tabulating it. And that data has clearly given us these 4 points. Feeling that they were not heard and they were not attended. They very clearly on affidavit to say they feel they were alienated. They were not attended at all. So this is maybe actuality or this may be perception. But how are you going to address that particular perception of the patients when you are relating yourself to the patient? That is what you needed to understand. Second one is nobody seemed to have cared. Again, it is extension of being alienated. The third one is bad outcome, unexpected results. Here, I just would like to say one thing. I'm not a lawyer. I'm not a doctor. Being a lawyer, I'll tell you, unexpected results, I'm not saying, some sort of a things completely going wrong. I'm only trying to say there are a good number of cases where doctors have given some kind of a rosy picture that would be all right, but that sort of expectation of the patient is not met. So this is what we have clearly culled out from the affidavits submitted to various tribunals. And finally, heavy economic loss to the patient. They would try to take a chance. I have lost so much of money. Is there any chance of me recovering this money? One way is to litigate. So they are taking some kind of a speculatory route to recover that. So these are the 4 very important sort of things. What are the insights? See, with my 18 years of experience as an academic lawyer, these are the insights I think I would like to share it with you. None of them are something which is very, very virgin or new ones. But still, they are the ones. One is training and capacity enhancement. Today, the time has come. The doctors should have some kind of ability to appreciate law and changing legal environment. Like most of the doctors who enroll for our postgraduate diploma in medical law and ethics course, they are very, very unaware as to some of the basic aspects, like what is a criminal case, what is a civil case, what is summons, what is warrant, what is contract, what is enforceable, not enforceable. They are, see, at a very basic level as a doctor, when it comes to doctor-patient relationship, you are taken to a right. But when you start your entrepreneurial journey, that is, you have now trying to expand your so-called practice, profession. At that time, your so-called angel investors try to take you for a ride. So there is something you needed to do so that the doctors are at least taught some sort of rudimentals, because ignorance of law is no excuse. Communication and relationship management, much has been talked about that. But, we did try to correlate as far as our ongoing study. Wherever the doctors are not held liable, let's say they have gone to the tribunal and doctor is absolved. They have gone to the Supreme Court in appeal, but there also the doctor has been protected. What exactly prompted? So we did try to correlate. More than anything, one factor we consistently found out, somewhere the patient himself very clearly says to the tribunal No, I have nothing against the doctor because he was well attended. Somewhere that has influenced the tribunal members and the court. Yes, this person is only speculating to get his money or whatever may be the thing. So a good relationship, even one sentence by the patient has turned the cases in favor of the doctors. That is a correlation we could able to find. Handling media and public authorities. Please understand, media, especially social media, is playing a very, very critical role in our decision making. And judges and courts and tribunals are also victims of that. So you need to be very clear. So managing not only the battle inside the courtroom, but outside and handling media, you've got to be very, very careful. And then finally, I'm saying professional data building. This is where, it's an August gathering, culmination of many associations and stalwarts and opinion creators of the profession are here. I wanted to raise one thing. We started a think tank and we are running that think tank still at National Law School. But today, we do not have a data where a law, legal litigations against doctors. We don't have one archive today in India. So that is why it is becoming extremely difficult. Maybe because of my interest, I concentrate on National Commission and Supreme Court. More of a Supreme Court because this is the apex body. But these are not the only two institutions. We require some kind of an archive. Then only we would be able to understand by manipulating the data or scratching the crunching data, what they call. We can able to understand and take many more, what you call as a policy level decisions. So I would only urge all the people who are here today, please understand, you need to engage at 2 levels. If you are people like, who have excelled, all the people who are sitting in the front few rows, you need to engage at the policy level and try to address the issue more, holistically. And those who are, let's say, shaping their career, aspiring to shape their career, they need to engage at a transactional level and hone their skills. So that alone is going to really address the issue, is what my belief is. So, ladies and gentlemen, without taxing your time and the organizer's time, I take your leave by thanking the organizers for giving me this great opportunity to share few of my thoughts. Thank you very much.
Thank you very much, sir, that making a subject who are putting it in a very nutshell and explaining all the facts regarding to that. Yes, we are lacking in data. I'm sure that is most needed things that IMA is already on the mission. Definitely we will be coming out with the data of the cases which is on the medical legal cases. The next, after we hearing the law, now we have an ethical man coming to talk to us on the ethical challenges in the medical legal practice, the dilemmas which we are going to face. I'm sure that he will be able to explain to us in detail the concerns of ethics to us.
Yeah. Afternoon, Chairman. No, yes, yeah. Today's topic is on the role of ethics in the control of violence against doctors and healthcare institutions. Well, no physician, however diligent or careful, can tell what they or are may not be the object of some undeserved attack, malicious accusation, blackmail, or suits for damages. This is a statement from a famous American journal written 155 years back. This goes to show that attack on doctors and violence against hospitals is not a new phenomenon. And doctors today are it is on the other hand, the frequency has only increased. And today doctors are all apprehensive of violence at their workplace. Hence, there have been a clamor from the medical fraternity to have stringent laws and a demand for healthcare institutions to be considered as safe zones. It compels us to ponder Is this attack on our esteemed colleagues at hospitals really a law and order problem? Definitely, these stringent laws, these transgressions to a certain extent. But if then stringent laws alone were the panacea for all societal ills, especially in a democratic country like India, I think India would have been free of all heinous crimes like rape, murder, assault, and other criminal offences. One critical facet that demands immediate attention is the ethics, because ethics is the pillar on which the foundation of doctor-patient relationship rests. And IMA has a huge responsibility of addressing this ethical issue. As we seek solutions to these grievous problems, I would say by merely focusing on stringent laws, we are missing the tree for the woods. Well, one of the important aspects of ethics is human dignity and human rights. So human dignity refers to the minimum dignity that which belongs to every human being. And in healthcare, there's a threshold or a line beneath which the treatment of any human being should never fall. Coming to human rights, the very fact that you're born human as a human being, you have certain rights. It's defined internationally, nationally, at the local level by various law-making bodies. They are inherent, they cannot be taken away, and they are supreme. We talk so much about human dignity and human rights, but what is the situation? This is the situation across the country in many of the government hospitals and medical colleges. Patients sharing, unknown patients sharing the same bed, patients lying under the bed, under the cot, in the corridors. This is the sight which we see. Is this human dignity? It have been improving, but it's a very slow pace. We talk about human rights, and there have been several violations of human rights. I'm not going to all of them, but I would just like to highlight on one important aspect, that is an organ transplantation. In fact, in India, we have made remarkable progress in organ donation, thanks to the dedicated service of many of our colleagues who have displayed their skills, surgical skills, by saving lives by organ donation. Unfortunately, the spotlight is often on the disconcerting stories of kidney and other organ donation rackets, which is perpetrated by a minuscule of doctors among us and the institution and intermediaries. Thus undermining the image of the doctors and the profession as organ marketing. I think it is important that we, as an association, intervene and find a solution to these problems. Well, we talk about human rights of patients. What about the human rights of doctors? This is the scenario in most of the institutions, especially the resident doctors. And the chronic sleep deprivation and the exhaustion that these doctors face, leads to certain errors, several errors in endangering life. Very often, when a patient comes to the hospital in the wee hours, expecting the best care, what they often confront is a drowsy, tired doctor struggling to conduct his proper examination. The patient feels that they are neglecting him without knowing the plight of the doctor. The patients definitely deserve better care and compassion. And their frustration is understandable. Definitely, there is a compassion crisis in healthcare. Training in the medical field is, notorious for, destroying whatever compassion. It erodes all the compassion which you have. Medical training is very, very tough because of the exhaustive curriculum which we have, the inhuman conditions in which these doctors are working, and it just takes away all the inherent compassion which all these medical resident doctors have, and this leads very often to burnout among healthcare workers. And as a result of this lack of compassion, I think we are doing a disservice to the patient, and often it ignites hostility against the doctor community, I would say. As an association, we have several associations. As an association, we have to intervene and try to bring in reforms of the duty hours of these doctors, not only for the well-being of these young doctors, but also for the service they provide. The other pillar is the benefit and harm, which we talk about ethics. And MCI or NMC guidelines of sales do not overreach. The doctors should not try to treat patients beyond the training and the facilities they have. And they should, if doctors have any sort of incapacity which is detrimental to the patient, I think they should restrain from practicing temporarily or permanently, depending upon the severity of the incapacity they have. Coming to prognosis, I think very often, I think many of the speakers have said of this, very often doctors have a tendency to amplify the seriousness of the case and, and advise invasive procedures. When they go to offer a second opinion, they are managed conservatively. On the other hand, there are instances where doctors tend to hide the seriousness of the case, hoping that they would go to a better equipped institution. In both these instances, what happens is the loss of trust. And trust is the basic foundation of this doctor-patient relationship. And this deterioration of doctor-patient relationship is the root cause of violence against doctors and healthcare institutions. We have autonomy, another important pillar of ethics. And we say that patient autonomy means they should be made part of the decision making. So what happens that very often what happens is that the patients generally do not comprehend the gravity of the situation, probably because they have not been well informed by the treating doctors, and it is often exacerbated by the lack of time. As a result of this, what happens is that there is a lot of misunderstanding, and as this previous speaker said, unmet expectations, and this is one of the reasons which triggers violence against doctors. Unfortunately, a very minuscule percentage of doctors have got any sort of formal communication, to training in communication, because it is not in our curriculum. Of late, it has been included, but how far it has been effective is a question to be seen, after a decade later. We'll see. Coming to the other aspect of ethics, we have empathy and sympathy. I'm not going to that. We have what is empathy, I'm not saying, but then, so what happens is there is something called the intensifying apprehension surrounding the illness and the huge burden of the cost factor, which actually it causes a lot of anxiety among the patients. And this is one of the reasons where there's a surge of violence against these. So doctors or healthcare professionals should be well trained on how to deal with these they should be well aware of what are the various anxiety alleviation techniques. Opaque billing, I think it has already been discussed. Opaque billing is one of the most common reasons where it is a catalyst for various violences. And Breaking Bad is, I think, unexpected or the abrupt death of a loved ones. It often culminates in an in emotional turmoil, and then it results in an outburst of violence. I think every doctor should be trained in how to communicate to break bad news, because it should be told skillfully and sensitively, because it helps the patients and the family members to navigate through these emotionally charged situations. And justice is another important aspect. John Rawls had said that the stability of a society depends upon the extent to which the members of that society belongs, and the very foundation have been laid for social unrest. So there are different types of justice: distributive and procedural. And distributive justice is giving, these resources, distributing resources It's a very important aspect, and every doctor, those who are, who are deciding on these factors should be aware of these things. And elements of justice. We have been talking about distribution of resources. This is how, when you equally distribute resources, you see that fellow in violet, he is not very happy. The rest of them are happy, but the fellow in violet is not happy, even though he is being helped. But if it is equity, when according to the need of the patients, according to the need of the group of people, then you see all of them are happy. But actually, what we always want is liberation, no barriers. But what is the reality? The reality is the rich, the powerful, the influential siphon away all the resources. The poor, the undeserved, the underprivileged, the needy, they are suppressed. This is the reality. And procedural justice is when you don't, the justice delayed is justice denied, and very often violence is because of that, and because of a huge out-of-pocket expenditure. We have always, the because of the rise in the advancement in technology and science, medical science, the total healthcare expenses skyrocketed, and it is often believed that it is the doctor who is taking away, though it is the expense high, only a small majority is taken away by the doctor. But there is a misconception that it is the doctor who takes away the money, and there is a misconception that it is the doctor who is responsible for these investigations and the medicines. So he is actually to be held accountable. That is what the misconception, and it is often exacerbated by these adverse reports, like all these cuts and commissions, hospital money on heart steroids. This is, these are the things which come out in the press. I think it is our duty, the duty of Indian Medical Association, to ensure that our brethren do not practice unethically, especially on cuts and commissions and freebies from various pharma companies and other, consumer companies. To conclude, I would say that attack on doctors is a social evil. It should not be tackled merely as a law and order problem, but it should medical ethics have a huge role. I may have to demand major fund allocation on health, infrastructure, and human resources, and healthcare delivery should be increased. The medical care should be compassion and skillful communication, and media have to be responsibility. And finally, I would put it in the last. It's effective action and stringent punishment and those violence. Thank you. Stay strong, stay safe. Thank you very much, Mr. Kumar and Dr. Nandita, for this exploration. Now, this is about making conflict, and probably this panel sums it up all. Because on one side, we have the medical expert, and on the other side, we have the legal expert. And medicine today is nothing but the practice of medicine. Now, it is a seesaw that we have the lawyers to use so that and the lawyers probably want the medicine, not the medicine, but otherwise, when there's a legal job or when the medicine is using, the lawyers are giving. But it should be so. And I think Dr. Nandita in the last slide that exactly needs to be done. And probably this, alliance of the opinion makers of the country brought together today. Probably we can slice it to things which you mentioned. The first one we training on law and ethics, and there's probably no other body like IMA reach every doctor in the country. And probably why we collaborate with API, not to get experts also legal experts. And the second thing is relationship, which is absolutely important. And I marked a project which we did in Kerala called the Patient Care Scheme, where doctors will contribute to charity, which was and utilized for patient services in small hospitals giving free treatment. And in addition, all the charity activities of all the IMA branches were tabulated and brought to the city website. And when if you realistically do that, it would be much more than the entire government health budget. So such an attempt, how do we are doing, but we are not already. So probably IMA can put that in place. And the third thing, whether we like it or not, media management becomes absolutely important, especially social media. Our fourth and the final thing is research. When we talk, we need data, and probably we have to take it forward from there. So thank you very much for that excellent speech to both of you.
Thank you very much, both the. Thank you very much both the speakers for enlightening us on the issues of the law and ethics. Ethics is changing. Ethics is dynamic. Ethical dilemma is inevitable. Definitely, medical ethics, Indian Medical Association, and your it's all helps you in ethical dilemma. And it is true, evidence-based. When you follow ethical principles of autonomy, beneficence, maleficence, and justice, especially equitable justice, the incidence of cases filed on the incidents of violence as negligible in the case of people who are following ethics to that level. So let us prove the law is there to safeguard us only, not to punish us. Ethics is there to help us to overcome the cases are going to be on. There is a by the Medical Association to organize a mock even like this with a whole event where we are discussing this issue. This will benefit us. This will make sure the future of healthcare will be safe, not only for the patient, but also for the professionals who are going to practice it. Unless the healthcare professionals are healthy, the nation's health cannot be healthy. So let's ensure that health profession and healthy people are going to live for long. Excellent presentation, sir. So I'll just take one minute, 30 seconds. It's a completely different topic. The All India Medical Conference, which is the National Conference of Indian Medical Association, is happening on the 27th and 28th of December at and as chairman of the organizing committee, I request all of you to kindly come over. We will have much more deliberations also there. And also, if you need any logistic help, I'm here. Please do contact me or any member of the organizing team. Thank you so much.
Thank you and many, many gratitude, sir, the constellation of eminent speakers and chairpersons for their enlightening talk. And please kindly collect your mementos for sure. Now I hand over.
Good afternoon, everybody. We come to the last technical session, building an environment of safety within the hospital. How are we going to do that? And we have the chairperson, Dr. Rajan Sharma, the past national president of IMA, the chairperson for the next session. Dr. Rajan Sharma. Agavi. Co-chair, Dr. Sarjanand Prasad Singh, also former national president of IMA. Sir, Sarjanand Singh, sir, please come on to the right. He is there. Okay, thank you. And we have two speakers. Dr. Girdhar Gyani, Director General, who will talk to us about the building safety culture. And we have Dr. Ajay Kumar, Executive Chairman of HCG Group of Hospitals. Dr. Ajay Kumar, sir, please come in. Sir,
I would like to invite, starting off, like to invite Dr. Ajay Kumar, Executive Chairman at HCG Hospitals, to come and raise it as Dr. Girdhar Gyani, please, sir. There's a slight change of schedule, so Dr. Ajay Kumar will be giving his talk first. Dr. Ajay Kumar, please.
Is it ready?
Okay, Girdhar Gyani.
Can you change the?
सर का चेंज कर दीजिए दूसरा वाला है.
Okay. Good afternoon, everyone. While we are getting ready, I will sincerely thank the organizers for having invited me. Next person. I am the next. Huh? No. This is his talk. My talk is next. Ajay. Okay. So while we're getting ready, I just want to also thank Dr. Girdhar Gyani for having given me the first spot. I just want to say this while we're preparing. Some of the things I'm going to say is my own experience, having practiced in US for 28 years and started a group of chain of hospitals and HCG in India, 25 hospitals. What I would like to say is
that what is the learning curve for me about violence doctors? While we measure cancer outcomes and all, we deal with difficult patients, come with lot of hope, aspirations, and how do you deal? And why is it in the last 2 decades we in across India 23, whether it is in Bangalore, Mumbai, or Ranchi, or Gulbarga, or Vijayawada, all the places, there has been no issue about violence. What is the take home message for me, and what is it I would like to share with you? Is what I thought I will go through. Here I want to talk about one incident happened in US, where a prominent Indian who was head of the South Asia Studies University of Chicago years ago was very healthy. He had a small benign lesion on the spinal cord, and the doctors in University of Chicago, who were a very close friend of ours, said they will operate. And when they put him under anesthesia, he died under anesthesia before they could operate. Now, why is it there was no violence, nothing? It was possibly a litigation matter was taken care of. And similar things in India, obviously, depending on where it happens, there could be issues. So the important thing is where it happens and how it happens. You have all heard today a lot of things about communication and why, what we should do, what are the things. But I would just like to take on few things. It is what we call as aspiration, how we brand ourselves, what is aspiration, what is the who is the doctor, how the doctor communicates. In all my 48 years of practicing, and today I practice advanced and recurrent tumors, one of the most difficult challenges, patients come with advanced with lot of hope. I think one of the things I find in order to really look at it is, do the doctors require training post their MBBS, MD, or DM course? What kind of training they require? Again, the training is not static, it is dynamic. Can we perpetually do, or should they be mentored in this? What is the body language? Are we treating the patients as though they are our own brother, sister, or, parents? Or do we have this connection? In my experience, I find once you make that link, that you are caring, you are listening to them. And one of the things I like to tell in my practice also is very successful. People came from 100 miles. When we make rounds, for example, if the doctor sits by the bedside and talks to the patient without looking at his watch or mobile phone, it makes a huge difference. If you are there standing, repeatedly looking at it or talking to your associate something and then and pretending to be listen or not listen, then they get a different view. Because we have to remember, patients come from maybe close by or from long distance, and their expectation level is high. And you have to somehow put a system in place. The system I call is when they enter, how the introduction is done about the doctor. Who are your people? Who are your ambassadors? Talking, you may be extremely busy. In my own practice, I used to see 100 patients a day in Chicago area. Within 1 year, I became very busy. So after a few years, the new generation of doctors came. It was 99% white population. And one of the things they asked is, what is so great about Dr. H.I.? Why is it? The important message they gave him is, he doesn't, any number of patients he may have, but he treats me as though I am the only patient. How do you communicate? For example, I'm running late. I'm 15 minutes late, half an hour late. You have to send word to the waiting room or call them at home, which we do diligently. Look, doctor is running late by half an hour. Please come late. Or when they come, can you go and have a cup of coffee and come? We are waiting. That shows, I think, that concern for them, their time. We should never take it for granted. Their time is not valuable, but our time is valuable. That is a wrong assumption. I think their time is as valuable as ours. Maybe they don't have anything to do all day. Maybe they are retired. Maybe they are sitting at home. But don't ever assume that their time is not valuable. And however busy you are, one of the other things I learned For me, saying I'm busy is a no word. I think we have to eradicate from our dictionary. We should never say I'm busy. However busy you are. Everybody is busy. Busy is a term which should be completely booted out. And we should learn to say, look, if you had an emergency, I'm in the middle of this, can I be a few minutes late? Can I, and nowadays, of course, SMS and all that can be done very well. And also the other thing we should look at is, we always say, the patients look at the infrastructure, the bathrooms, they are all important, of course, but I don't think because of that, the patients will go into any violence. It is really the expectation game, and to me it is how you communicate that and overcome that with expectation game. One of the things I find in India today, doctors are communication abilities certainly lack. And I think my own daughter is in final year, and when I quiz her and ask her about the class, I think they're so focused on their curriculum, there is not enough time given for communication skills, which we believe we are pushing across, at least in Karnataka, to really bring about this education level in terms of communication. How to meet, for example, I always give this example, like a person who comes for employment in a city, who has done his, let us say, doctor, who is a MBBS, MD or so, and person who comes from rural area, there is a difference in the communication. Be it an MBA course, MBBS, whatever course. How do you bring them up to the industry standard so they can communicate? Other issue is language. People nowadays migrate from different parts of the country to other parts. Fluency of the language is not there. People misunderstand. They don't know what they did. And the other issue we heard about is the social media, which is very powerful. But contrary to what a lot of people advise, I have a philosophy where I tell the patients, please do all your Google search and come. Do everything possible under the world. And you come with questions. Now, what I do is, because I train our doctors that way, because I know what are the expectation level, because we do a board where I anticipate their questions. So what I do is I go and answer before even asking them, these are all the things, cancer is this degree, you got this stage and this is the problem, these are the treatment, this is the expectation game, and what does cure mean, what does remission mean. Spend about 20 minutes explaining, then I ask, do you have any questions? Very rarely they say, I have more questions, except financial issues. Financially they ask. And I have a medical social worker who answers. But it really creates the bond, because the patient begins to think, my God, this doctor knows what are all the questions I'm going to ask. And he has sat with me and explained everything. And the time you take for that is literally not more than what you would have normally spent going through a questionnaire with them. So you preempt that by showing that confidence, and they feel that this doctor is also good, confident, so they begin to trust. One of the most important things here I want to bring is the trust factor, because when we see in oncology everywhere, we did a study with PwC. MD Anderson, where I trained, I compared to HCG about 8 years ago. Okay. MD Anderson put at a trust factor of 75%, whereas our hospital stood at 45%. So what does it show? People come, they have to come and trust. When they don't trust, obviously it can lead to some form of violence or whatever you want to call it. So you have to build a trust. That is important to me. And another thing is, how do you handle the families and everything if that death happens? Can you go and put them in a separate room, talk to them, offer them coffee, and get one of the senior consultants to talk to them? I think that is very important. Who knows the case, discuss with them. And dealing with patient and husband or wife is different. Dealing with families is different. Sometimes unknown family member comes and creates all kinds of noise. How do you avoid by having a single spokesperson for that family? The important thing, you say, you designate a spokesperson, I'm going to only talk to them. And that also beautifully works, because that person who is good in communication. So these are some of the things I would like to look at, in spite of a lot of other things. And body language is important. Like when you see the patient first time, you can understand with the body language, is that going to be a cooperative patient or a hostile patient? Based on that, within 10 minutes, you will know more or less. And that study the body language and appropriately construct them how to advise, how to talk. Because you have to go a little bit more into details and pat them on the back, take them into confidence and explain that, and automatically they become more friendly. You can see a smile on their face, which very quickly happens. So these are some of the things I believe we have to do in order to kind of positive solutions. Of course, waiting, environment, all of these are there, but I have touched upon some of the important points, creating an environment. Particularly in cancer care, as you know, gloom and doom, people think, what is it? And they can become hostile with the cost. How do you address the cost is another issue. In the cost, the most important I find is to be very honest. When you give an estimate, particularly they trust the doctor. They come to the doctor and show, is this a correct estimate? If you give, in spite of what the administration says, I think here the doctor has to separate themselves with the administration. Even though I pray both, my doctor, what I tell them, you decide and you say this, we have to stick to that, plus or minus 5%. If it goes extraordinarily high, we have to explain to them why it is high, what are the reason, maybe ICU, antibiotic care, everything else. They should be part of the team. You have to make patient and families part of your team. Otherwise, it almost definitely leads to the hostilities. And then, of course, if we run out of all of that, we have to be the first one. Recently I had a problem with the patient from somewhere outside of Bangalore, and the doctor was very nervous. These people are going to do something. They want a little bit money. I said, nothing doing. We called and counseled them. Please go to the courts. Please go to Consumer Society. Please take legal action against us. We volunteer it. If you want any help, I can even find a lawyer for you. That shows our confidence that we are not going to buckle down if we are on the right. So never buckle down. Sometimes what happens, some administrators and all want to cut it short. Why all this trouble? And when people say media on a light-hearted way, I want to say, I had this experience. I will go to media, I'll call TV, the TV. Really? Please call, we'll become more popular. People will come to know HCG as a big cancer center in Bangalore. Please do. I always encourage them to go to media. What happens? So these are some of the nuances which is, if you can do, I think we can overcome. And part of the reason I'm standing confidently and saying, across India, we have never had any problem, violence, never any physical, occasionally verbal shouting and all. I have been successfully able to manage, I think, because of this effective communication and contact and answering their questions, be sympathetic and smile. With a smile, you say, okay, this is what it is. And then there is a depth, show your concern. And majority of the time, you will be surprised, contrary to the belief, when patients expire. Recently, one of the top bureaucrat expired, and it was expected advanced case. His wife wrote a nice letter to me after that, how well it was taken care of, everything. Similarly, so that is a hallmark of how you have taken care of this. When tragedy happens, they will write a letter saying, and then they say, what can we do next? They become part of your group. So these are some of the things I think we have to do. In this training is very important. How do we train is the challenge, because doctors come and go and you have to consistently keep on training new group of doctors. And it is cumbersome, it may be even expensive, but one word is, there is nothing like a master trainer in this. In all our groups, we always say, our administration, okay, I got this expert coming from Mumbai to do. From Bangalore, then nobody is an expert. Like I say, in oncology, after 48 years, I am not an expert in oncology. There is no expert. It is common sense. Write down the common sense and impart the common sense to your other doctors. You are yourself becomes an expert. You can counsel, you can do. Of course, advice from experts may be needed, but expert coming once and giving this talk and going away will not help the situation. You are unnecessarily, financially, you're causing a burden. Financial healing, last but not least, is very important. I think we have to financially address, and we have to be willing to say, okay, for example, if I give an estimate of 3 lakhs, if it becomes 6 lakhs, you have to either explain to them why and what is it, or write off. and you cannot go again. Then you get a discipline. Once you start writing off, people will understand that, hey, I can't keep on doing it. Because some of the people in administration tend to do because they want to show better revenue, better EBITDA, better margins, all of that. But as a doctor, you have to put your foot down and threaten them. And the other day, what happened was a doctor came from Nigeria, a family practitioner, very good. She has come multiple times. Her mother is the patient. She needed extra treatment with cyber knife. Normally, it costs about 5 lakhs. And she came to my, I seen her and went back to my clinic to see, and she butted in and said, I want to talk to you, doctor. I said, what do you? Then she was hesitant. Then the associate said, she wants some discount. I said, why are you asking for discount? You had so much treatment here, and now you want to ask for free treatment. So I made a treatment free. I wrote off completely 5 lakhs. Amazing expression, and she will be our ambassador forever. We have to go this out of the way, out of the box thinking to make it happen. We cannot be succumbed by corporate hospitals. They don't allow to meet. You need to back people of the institution, not the administrators. So do what you think is right and threaten the administration. Then I think they will buckle. So do the thing right. With these few words, I would like to conclude, and thanks for having me here. Thank you very much.
Thank you. Thank you, Dr. Ajay Kumar. You told us a very different aspect, which we pass at the ground. Maybe it's a wish list which all doctors, the patient should move that way, and we can move off. Thank you so much. Now I invite the next speaker, Dr. Virendraji, please.
Thank you very much. In fact, as you know, this talk was to be delivered by Dr. Hari Prasad. In fact, yesterday afternoon only he conveyed the message that he was running temperature and unable to come. So Dr. Sharad Agrawal called me. He said, I have been speaking on the same topic at Surat. So why don't you come in? I said that was patient safety culture. While you are asking me to speak on safety culture. So what I have done now from my slides, I removed patient and speaking on safety culture. Anyway, I think one thing I would like to say that when we were designing these 5 sessions, these are all very distinct sessions, no doubt about it. But over the period of time, I'm saying we can't avoid having overlap. Because ultimately, the main issue is the violence. So ultimately, many speakers try to overlap each other, but that is fine. Now, I think I have about 8 minutes if the Honorable Minister comes in time. So I will try to speak from that angle. And I think this is my small, message to all of you is, I have heard that to improve the safety culture in or safety rather, in the hospital against the possible violence, we must hire a good security organization. Somebody will say we must strengthen security in the OT. Somebody says strengthen security in the emergency. Somebody says improve security in the registration desk. I tell you, nothing will work. Unless you take an approach when you have a culture of safety in the nursing home or in the hospital or even in the clinic, nothing will work. So I think my simple message to you is that this culture, as you know, will come. How do we, train, how we institutionalize, how we empower our doctors, nurses, paramedics. In fact, yesterday in our meeting, our friend Commander Navneet Bali was saying that doctor is like a captain of the aeroplane who is not in contact with the passenger, and it is only the crew staff who have to be groomed, for on communication, other things. But then later on, our discussion was that in healthcare, doctor cannot be compared with the captain because he is also interacting with the patient. So I think ultimately everyone has to be part of this culture. And this culture, of course, we keep talking about systems theory. And you know, the systems I keep defining when you say if the hospital is system based, many of the hospitals are doctor based. You know, I will not name, suppose, oh, this hospital is known by that doctor. So we become, this hospital is run by, I don't want to use the word whims and fancy of that one individual. Now that kind of hospital will not be able to develop the culture, because culture has to be down the line from top to bottom. And that is where we say the system has to be, and system is defined by what is to be done, by what is to be done, how it should be done, and on what basis protocols. Once you have this clarity down the line, I think your hospital then is known as system based. Now, these are the 10 points I picked up yesterday afternoon, which I will not go into detail because I think a lot of things have been talked about. The training and education to all the staff members on the topics. I think my previous speakers have been talking about it. But you know, this point of training and education we take very, very lightly. I remember in the automobile industry, they have a fixed norm. Each worker has to be given 14 man days in a year. Supervisor, so many man days, so and so. You know, that kind of, you see in the seminar, in the healthcare, many times I find from one hospital, same two persons are coming here, there, only these two persons are coming. I sometimes wonder, why only these two and three? Do they not have any work in the hospital? Or they are super duper intelligent people, but that kind of, you know, status or this kind of working will not work. You have to institutionalize the training, retraining. That is where this policies and procedures. You know, we have to define our policies, or more importantly, the procedures, and that have to be implemented, you know, in letter and spirit. Third point is on the risk assessment. The risk factor keeps on changing. If you now see that ISO, these people have incorporated risk assessment and risk mitigation in all the international standard. All the management standard have this one. Same thing has now been incorporated in the NABH as well. But whether you are NABH or not, you have to carry out this risk assessment by engaging the professional. You can't be really doing the risk assessment of your own. Risk is physical, risk is financial, risk is ethical, risk is any type of risk. You must carry out this assessment and mitigation. And that is the way it has to work. Collaboration and communication, I think this lot of things have been talked about. I keep telling health industry people that this is the industry, it is known for fragmentation. I think in spite of all efforts of IMA, HPI, we have still not been able to create that united front of the industry, and that is our weakness. You know, the day you start understanding that once I collaborate, I am saving myself and I am saving others, because this is the one weakness. I think gradually we are trying to, you know, bitch on this one, but this is where actually leadership involvement, of course, that goes without saying, that you have to drive the safety culture. You cannot say, okay, so and so, the security officer, so and so officer, that will not work. You have to lead the safety initiative from your side. Last is the community engagement. I think this is the best one. If hospital is able to engage with the stakeholders around your location, let us say within the 5 kilometers, within the 10 kilometers, if you are engaged with the housing society, with the local governance bodies, with the police authorities, or so and so and so and so, I tell you, you will be feeling yourself much more safer and secure. So this is the community engagement. Empowerment, of course, is the best thing. Empowerment is the one which I keep talking in all my talks. If the top management is able to empower the people down the line, I keep telling them that you can take it. Go to the station and enjoy it. Hospitals will keep running. Today, I find most of the CEOs, they say, oh, I can't take leave for 2 days. Who will run the hospital? I think that is the insecurity because you have not created the system. You have not empowered the people down the line. And empowerment means taking ownership. If you say, I am empowered, unless the people have taken ownership of the processes, that is not, empowerment is not complete. So I think it is really a sustained effort. Let me tell you, it is not very easy. Empowerment is not very easy, and so use of technology is going to help in a big way, and I think we are doing it almost. This is what I call diagram of empowerment. We call it inverted pyramid, where the top management is shown to be sitting in the bottom. Basically, why is it shown in the bottom? Because he or she is taking the whole burden of the organization, and through empowerment, and maximum empowerment is coming in the frontline staff, which are doctors, patient registration, OPD admission, consultation, discharge certificate, fee collection. If you can empower these people, I tell you, about half the job is done. Because they will take care of the patient, including violent patients. So this is where actually we stand. And this is, I have already explained to you. And so one of the aspects which people have talked today, I come with the background of the NABH, and I can definitely say that today, clinical quality has improved drastically. I think each doctor today knows what is surgical site infection. He can really tell you this is the measurement. But unfortunately, I'm watching of late good hospital, even including what we call them top branded hospital, there the patients are drastically complaining about the service quality. I think one of the reasons can also be that if you are not able to institutionalize service quality, this can result into a violence. I think I have just kept a few points in front of you that like clinical quality, I think I will advise you strongly if you want to make the brand of the hospital, focus on service quality. Because the patient doesn't understand what physician, what surgeon is doing with him or her. But he or she understands what kind of empathy, what kind of communication you are showing to the patient. So I think this is a very, very important aspect. If you are able to aspect into your system, and my last slide is these are of course takeaway. The safety culture can only sustain in a system-based organization, not person-dependent organization. This is one. Empowerment and leadership are the key mantras. So please remember, empowerment is not an easy word. It is not delegation. Empowerment, you delegate after making sure the person whom you are assigning the task is capable of doing that through training, skilling, reskilling. So that is empowerment. Frontline staff ought to be well versed with a soft skill and empathy. Again, not very easy job. I think I can assure you, I have seen all the hospitals. It is not an easy job. We are not taking care of it. We are not focusing on this very subject. Well established documented system and good record keeping. Transparent accounting and blink criteria definitely is one of the major cause of violence. In fact, in my personal opinion, it is the cost because there is a perception in the society and which has been further, जिसको कहते हैं ना आग में घी डालना, has been done by our people in the power. Because they keep telling you that private hospitals are profiteering. But this message which has gone down for a number of years, we have not been able to counter that. So in my opinion, because we have not been able to remove this perception that healthcare has a cost component. And once we are able to do that, I think our majority of the causes of violence will go out. So for that, transparent accounting, keeping them informed every day. It should not happen that first day estimate is so and so, third estimate has become double. So that you have to keep on sustain relationship with the community and law-making agencies, formal networking with the hospital and nursing homes in your own areas, and finally, most important is in-house, especially trained safety and security staff. So my simple message is you have to build safety culture, not take piecemeal initiative here and there. No, that will not work. Piecemeal initiative will bring you piecemeal results only. So I think with that, I hope, Chairman, I have taken care that if the minister comes at 1:30, our talk is over. Thank you very much.
Thank you very much, sir. I think the key factor in this entire gamut is happiness of the doctor and the patient, and the number of patients waiting outside. They should not be a target that so many are sitting outside and we need to finish them off. At the end of the day, we worry again what to do with that much of money. So it is better to spend some time with the patient. That's my humble request. Thank you so much.
Thank you, our chairman, sir. So, I just how this silence so about it. Sound. So we should avoid this thing. And always it's a matter of directions. I bring so just have a right where all other members and has coming. So I did a passing of patient time to we would like to thank the chairperson, the co-chair, and the speakers. And with that, for Dr. Vinay has an important announcement to make, please. Friends, we have just received a message from the Archbishop that the arrival here will be delayed because of the election results and all that. They are meeting the Prime Minister in the office because of the election results. My request we have a IMA declared that IMA violence, declaration on this summit. And then I request all of you to go for lunch. Lunch is on the first floor, but please come as fast as possible because the distance from the headquarters to this place is 5 minutes. And Minister has said that any moment he will get time, he will come. So my request to you after this, please come as fast as possible to the hall. That is my personal request to all of you. Right? Please wait. Lunch is not yet started. Please wait. Don't go out. We are having it.
Outside to come in.
Lunch is at please wait. We are having the IMA declaration on the summit and our issues. So please wait in the time and we are going to have this. Right.
All those fellows are outside to come inside.
Succeeding session is a very important session, and I would like to request all the participants to please be seated. Those of you who are in the auditorium, kindly be seated. And also, I request somebody to ensure that all of them come inside, please. Let us begin the session so that we can conclude at 4:45. Please be seated. I request all those who are standing In the rear of the audit, kindly be seated, please. Okay, go ahead. Go ahead, go ahead.
So we start with our formal session, and the inaugural session is postponed till our chief guest comes, he arrives. So I take this privilege to invite Dr. Sharad Aguilar, sir, our national president, Indian Medical Association. I also invite Dr. N. Naik, sir, honorary secretary general, Indian Medical Association. I invite Dr. N.X. Thomas, sir, AHIPI Advisor Health Summit. I invite Dr. Girdhar Gyani, sir, Advisor Health Summit. So please.
सबको बुलाओ तो यार
क्या और क्या आपको बोलना है बस बोलना है ओके अब बोल दो इनको
Welcome address.
हाँ अनिल नाइक को दो
पहले को भी बुलाना है
खाना मेरे पास लिखे हैं इसमें
नहीं अभी ये शरद ने लिखा है ये शरद ने लिखा है
अच्छा मुझे तो सर ने दिखाया था
शरद का हैंड राइटिंग
बाली डॉक्टर बाली
हाँ
I invite Dr. Chitut Bali, sir. Sir, please kindly come on the dais.
बाली 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 कंटिन्यू
Shan, sir.
Bali, Dr. Bali. Dr. Shishit Bali, please enable us to start the function, please. May I now request the Honorary Secretary General IMA, Dr. Anil J. Naik, to formally give the welcome address.
Who is going to pray? Vinay? Okay.
Good afternoon. I welcome our chief guest because he is in the BJP office live aspect, so I feel that he is not going to come. And Dr. Vinay is also given the message he will come anytime. So we have started a inaugural ceremony. Dr. Sharad Aguilar, Dr. N.X. Thomas, Dr. Girdhar Gyani, Dr. R.V. Ashokan sir, Dr. S.M.P. sir, Dr. Agarwal, Dr. Siti Bali, all the dignitaries on the dais, off the dais, and all my dear friends and delegates. A warm welcome to all the participants who are there for attending the National Health Summit organized by the Indian Medical Association in collaboration with ASPN, CMHO, and our esteemed partners. We are honored to have distinguished healthcare professionals, policymakers, citizens, and stakeholders from all corners of the country gathered here to address a pressing concern: violence against doctors, nurses, and healthcare workers. Our focus today is on the rising incident of violence targeting hospitals and healthcare personnel. The escalating acts of aggression in the workplace not only affect the moral of our already stressed out doctors, but also pose a threat to the entire healthcare team. This multifaceted problem includes verbal threats, physical assault, and vandalism. We extend our gratitude to our Honorable Prime Minister Sri Narendra Bhai Modi for condemning the acts of violence against doctors on numerous occasions. The Indian Medical Association has been at the forefront of the fight against violence on medical professionals and their establishment. Although 22 states have enacted the laws, the ground reality reveals their ineffectiveness due to lack of appropriate references in IPC and CRPC. For a long time, IMA has been advocating for a comprehensive central law that includes security measures and exemplary punishment for the perpetrators. We have also urged our amendments in the IPC and CRPC to address this issue effectively. Despite our persistent efforts, the draft act prepared by the committee formed by the government of India has not been presented in the parliament. Today's National Health Summit is a continuation of our dedication efforts. By bringing together our collective expertise, we aim to make a significant impact on this issue and create a safer healthcare environment for everyone. Let us unite against violence and work towards future where healthcare professionals can serve with security they deserve. Together, we can make a difference. Thank you. Jai IMA, long live IMA. May I now request the National President of IMA, Dr. Sharad Kumar Agarwal, to address us, please.
Honorary Secretary General, Indian Medical Association, Dr. R.V. Asokan, President-elect, Dr. S.N.P. Prasad, immediate past President, Dr. Kshitiz Bali, Finance Secretary, Dr. Vinay Agarwal, sir, past President IMA and advisor of this summit, I would say chief advisor of this summit, Dr. Alex, founder president of AHPI and advisor of this summit, Dr. Gyani, Secretary General, Director General of AHPI and advisor of this summit. Ladies and gentlemen, it's a proud privilege that we could address an issue which is the only issue related to medical fraternity today in India. We have a lot of issues, we can say a lot of problem we are facing, but this is the single issue which we are still not able to solve it completely. We have deployed so many brainstorming and find out some solution regionally or city-wise that we have created a task force, but still we are fighting for a central act against the violence from the government. And I tell you, lot of talks and lot of things has been done with the central government in last 1 year. The matter has been sent to the standing committee, and we have appeared in front of standing committee. We have given our presentation. Dr. Utra was there, Dr. Bali was there, and it is in the advanced stage. That is why this health summit has its more relevance of organizing it in Delhi. And as we plan that we will do a Delhi declaration on this violence on healthcare, which I will read after this. This is a very serious issue.
And IMA is fighting against this with the government. And I am sure we will be able to get this, because if by an amendment during pandemic, if the violence is not acceptable, then how can it is acceptable in non-pandemic situation? Because the doctors are the doctors, hospitals are the hospital, and patients are the patient. But of course, in the start of this year, when I took over as the president, we met our visionary leader, Dr. Ketan Desai sir, and we discussed about this summit, that we will be having this kind of summit. But that time I didn't know what shape we will be having. Then thanks to Dr. Vinay Agrawal sir, Dr. Ashokan sir, Dr. Alex and Dr. Girdhar Gyani, these four people, senior people, they sat with me and they asked, can we do like this? Ladies and gentlemen, this won't be possible if we would have not worked as a team. And I am very fortunate to have Dr. Anil Naik as the Honorary Secretary General, whom I always say my elder brother. He never said no. Whenever, whatever we discuss, he say, okay, we'll do that. And our young dynamic Finance Secretary Bali, who is managing our finance very well. And we could budget it out. We planned the budget. Yes, we tried. We should not be the over budget, but we were very clear in our mind that we want a health summit of this stature. And thanks, in top of that, thanks to all of you who made this health summit successful. Violence is not the issue, the problem of the doctors, but it is the major issue of our younger generation, our young doctors, our JDN. Because every day they are facing that kind of problem in the medical colleges, emergency. So it is not an issue of a single association, but as I said, when I took over as a president, my vision is one for all for one. I always mention that we, the doctors, we are divided in separate association. We run different association and doing wonderful job. As an association, different association, all the associations are doing very good job. But the perception in the ministry and the administrators that doctors are divided. Though it is not a reality, but they think like that. Because on every issue, there are 20, views from different representative body of the medical doctors. And they perceive that they are divided, which is again I am saying is wrong. And I knew this is wrong. The only thing, probably we have never initiated this, that we bring all the association on a single platform, that is the Indian Medical Association. Because nobody will be success if fighting individually. As we all know, Indian Medical Association is the largest medical association in the world, having almost 4 lakh members in its kitty, has the value. Indian Medical Association is completing its 100th year in 2028. So that is why my vision was to bring all the association on one platform. We already did 2 or 3 programs in entire year, and I am happy. I started this with the last December when I took over as a president, and now when the time has come to giving this baton to Dr. Sokan sir, that I am again completing this with a program one for all for one. Thank you very much, gentlemen, for supporting. Thank you all the associations supporting, and together we can win any battle. And you have seen entire year we have brought lot of issues. We solved lot of issues. Be it next examination, be it generic medicines, we were able to solve the issue through pursuance. In the end, I will read out the Delhi Declaration. which our committee has planned it. And we were very particular that this health summit should come with a declaration. And that declaration will go to the government also and the media also. I am reading it. If you can show it on the screen. I request Dr. Alex to please come here. So, Indian Medical Association, Delhi Declaration on Violence on Healthcare Personnel and Facilities. Point 1, Indian Medical Association along with AHPI, CAO, ANBI, Net Health, and the participants of the Health Summit on Violence, representing stakeholders from healthcare institutions, government, as well as law enforcement agencies, civil society organizations, and the general public take exception to violence targeting those who provide essential healthcare services. Recognizing that violence against healthcare personnel violates their human rights and undermines the well-being of our nation. We commit for collective action involving all sections of the society. Point 2, healthcare institution plans to implement comprehensive safety protocols, training program, and reporting mechanism to protect healthcare personnel. Simultaneously, they should foster a culture of respect and empathy for patients. We propose to eliminate the risk of violence by contributing to an environment conducive to vigilance and safety. The implementation of a system to screen patient and visitor is in order. Adequate medical, psychological, and legal support should be provided to victims of violence. Appropriate reporting system should be established to enable healthcare personnel to report anonymously and without reprisal. Aggregated data would be used to analyze the effectiveness of preventive strategies. Point number 3, we demand of the government to enact and enforce a strict and stringent legislation that holds perpetrators accountable for violence against healthcare personnel. A strong central law as well as a strengthening of all state laws incorporating the amendment to the Epidemic Diseases Act are in order. We will collaborate with healthcare institutions and civil society organizations to create a legal framework that safeguards healthcare personnel and deters violence. Government should allocate appropriate and sustainable funds in order to effectively tackle violence in the health sectors. Point number 4, we hold to account law enforcement agencies to investigate and prosecute incidents of violence against healthcare personnel. We will work closely with healthcare institutions to respond promptly, ensuring justice so that a strong deterrent is established. Point number 5, civil society organization will raise awareness through educational campaign, community engagement, and advocacy to prevent incidents of violence. They will mobilize public support and foster a sense of responsibility among the public. Point number 6, we call upon the media to raise awareness about this social malaise as well as report responsibly and accurately. The media can foster a culture of respect and appreciation by sharing stories of resilience and dedication by healthcare professionals. We encourage media collaboration with healthcare institutions, government bodies, law enforcement agencies, and civil society organizations to organize educational campaign providing true picture of healthcare delivery process. Together, we as a nation can protect the well-being of healthcare personnel, ensuring provision of high-quality healthcare services to our people. This collective effort will foster an atmosphere of trust, compassion, and safety, benefiting the healthcare professional and the community at large. This is the declaration we are going to send to the ministry also, and we are going to send it to the media also. And this will be a document which will be in the Indian Medical Association and in all the organization. And we will have more and more in, subsequent in the next stage. With these words, thank you very much. Long live IMA. Jai Hind, Jai Bharat. Minister will come little late. That is why we are escaping the lamp lighting and we are waiting for him to come because we want him to come and we want to give that declaration to him. So please stay with us. Thank you very much. May I now request Dr. Alexander Thomas to give the vote of thanks, please.
Thank you. Good afternoon to all of you, ladies and gentlemen. On behalf of the organizing committee, it is my privilege to extend a heartfelt vote of thanks on this occasion of the inauguration of the Summit on Violence Against Healthcare Workers. We are honored to have you all with us today. Chief guest, as was said earlier, will join us a little later. And we are grateful that he is going to come here, but more importantly, what he is going to do with us in the future. We would also like to extend our gratitude to our partners who have been of great support, namely who supported this conclave, namely UNBI, the Association of National Board Accredited Institutions, the Consortium of Accredited Healthcare Organizations, NatHealth, and of course AHPI. Their support has been instrumental in making this a reality and successful and led by IMA. I think collectively with the other healthcare organizations and stakeholders, it is a commitment to the cause of protecting healthcare workers. The organizing committee had been mentioned, but once again, I'd like to thank Dr. Sharad, the President IMA, Dr. Ashokan, Dr. Vinay, Anil, Dr. Bali, Dr. Gyani, and of course, from behind the scenes, we had Shikhar, Gautam, and Anthony from the secretariats. I think we actually started planning this about 3 to 4 months ago, and we used to have meetings every week. And I hope, and that has really been invaluable. Just as a recap, we'd just like to tell you what are the milestones in the recent years. First was the book, The Perils of Practice, which is there in your kits. We had eminent authors that was co-edited by Sajanand sir and a few others. This book has actually been a bestseller and has raised awareness in this critical issue, and that was what it was meant to. Additionally, I think all of you remember the recent very highly successful rally by the DMA, which showcased the effective strength of our cause and resonated with healthcare workers from all over the country. This summit, as was mentioned earlier, is an important milestone as we gather together, all of us, to devise a multi-pronged strategy to address this global emergency of violence against healthcare workers. Lastly, we extend our deepest gratitude to the faculty members and delegates from different walks of life who have joined us here. And I must say that we have members from the police, from the judiciary, from the media. We are also very privileged to have the chairman of the National Medical Council, Dr. Gangadhar, here. So it's a gathering of many different stakeholders, and we hope to work together. We hope that with our inputs and knowledge, this summit will prove useful and impactful in shaping the future of healthcare and ensuring the safety of all of those who are involved in saving lives. This Delhi Declaration has crystallized the way forward with a meaningful root cause analysis and effective actions involving all sections of society. And ultimately, as was repeatedly mentioned, it is the community, it is the patients which are going to benefit. Once again, thank you all very much for your valuable contributions, and we look forward to an enlightened summit and an effective and a good outcome in the way ahead. Thank you very much.
Thank you, everyone. Please, lunch is on a legal hall on the first floor. My personal request is within 20 to 25 minutes because we are expecting minister at any moment.
Thank you, boss.
Can the minister come and please?
Thank you.
ऑन है क्या? No, no,
Shad has come.
they have to.
No, I'm not there in this.
No, no, this one.
Bill, हो गया
नहीं नहीं हो गया ना.
हो गया हाँ इसमें
Yes, yes, yes.
शरद भी है अशोकन भी है. Sharath wants to be there, let him be there.
Right. Okay. I read. A very good afternoon. After a sumptuous meal, we are in for an exciting session. The most interesting of tonight's event will be the panel discussion, wherein we have experts in the field debating on various aspects of violence against hospitals and healthcare professionals, and how are we going to equip ourselves, equip the patient, and put an end to this menace of harassment to the medical professionals. I have the pleasure of requesting the presence of the moderator of this panel session on the dais, Dr. Narottam Puri, Principal Advisor, Quality Council India. Sir, please. The panelists would be Professor B.N. Gangadhar, Chairman, National Medical Council. Please come on to the dais, sir. May I request the presence of Mr. Guru Prasad, former Director General of Police, Karnataka. Sir, please come on to the dais. Followed by Professor Siddharth Mishra, Chairperson, Vivekananda School of Journalism and Mass Communication. Sir. Dr. S.M. Kantikar, Member, National Consumer Disputes Redressal Commission. And Dr. Sharad Kumar Agarwal, our own National President, and President-elect Dr. Ashokan. Dr. Ashokan, please. Over to the moderator, Dr. Narottam Puri. Thank you, sir. Yes.
May I request those of you who got your cell phones on to please put them on the silent mode. You can keep them on as long as I'm speaking because I speak the least sense. Moderators, to my mind, are required when people are fighting and you need to moderate. I don't expect any of the panelists to do so. Since you have such an eclectic and knowledgeable panel, it's wise for the moderator to speak the least. But I'll just introduce the subject and then it'll be over to them and perhaps to you for giving your suggestions, your ideas. Now, recently, an article in Outlook had this as its headline, and I quote, "Violence against healthcare workers is a silent epidemic. A patchy legal framework does little to address." Now, a few years ago, when the COVID epidemic struck, you will believe the brilliant Israeli socialist and historian, whom I love reading the books of, had mentioned this, that the real antidote to epidemics is cooperation, and the best defense is information. Therefore, I congratulate IMA for providing as much information as possible and doing the best possible to cooperate with other agencies, which is reflected in the choice of the panelists here today. I've spent about 55 years after my graduation as a doctor, and I've been very fortunate that I've not been subjected to any physical violence. But it will be wrong to say that there has been no mental or verbal violence. Some amount of verbal misuse by patients or usually by patients' relatives has been experienced by anyone who's practiced medicine over a protracted period of time. In other words, what I'm trying to say is necessarily violence cannot be just physical. It could be verbal, but it could be mental, as exemplified by the case in Jaipur where that brilliant gynecologist committed suicide because she was unable to accept the degree of mental harassment following the physical abuse to her center, despite the best efforts that she did to make the patient survive. In case records exist virtually on a daily basis, some element of violence the medical professionals are subjected to. Probably the doctors talk more about it, but the most commonly affected by mental and verbal abuse are the nurses. Many of these cases go unreported. So if we are to understand how to prevent it and how to manage it, as doctors, we need to understand the etiopathogenesis. What is the cause? Is it sociological? Is it psychological? Is it related to something that we are not doing right as doctors and nurses? And my friend, Dr. Alex, has written a book on communication about that. And I'm very happy that the National Medical Council has included communication now as a subject, because that's one of the major causes. So over a period of time, violence has come to stay as a part and parcel of discussion. But believe me, when we graduated or when we were medical students, we never heard of this term. We were still what was called then the noble profession. Somewhere along the line, things have changed. So India is now considered amongst the most unsafe countries in the world. And this is not me speaking, these are statistics. About 70% of doctors surveyed have pointed out that at some stage of their careers, they've been subjected to one form of violence or the other. So obviously it is an epidemic. That so far it used to be a silent epidemic, we didn't know. Now it is manifesting itself in all its glory. The loss of a life in Kerala of a house surgeon, the recent stabbing by a patient of a neurosurgeon at Delhi's Gangaram Hospital, or the attack at doctors and nurses at Faridabad recently, are just mere tips of the iceberg. To address this issue, the literature points out to 10 major causes, which I'm sure our panel will probably deliberate on, discuss, and from their perspective, give you an insight as to what they feel are the causes and the ways to manage it. One, as I mentioned, are communication failures on part of the medical community. When I say medical, it's a broad term. It includes doctors and nurses and healthcare administrators. Communication failures. The second is understaffing. The third is overcrowding. The fourth is less experience of some of the junior doctors who are posted in the front line. Fifth is the lack of awareness on part of the perpetrators of what is the need of the hour in behavior terms because of low literacy. The sixth is the unrealistic expectations. Sometimes they feel that anybody who goes to a hospital because they are in love with that person, he or she must survive. We know as doctors and we know as human beings that's not going to happen. We start dying the day we are born. So there are unrealistic expectations. Seventh is the emotional stress. Eighth, in particularly private healthcare settings, are billing issues. And it is very commonly said that when a patient walks into the emergency, the term that is commonly used by them is, Doctor Sahab, kuch bhi kariye, make the patient survive. Because doctor bhagwan hota hai, us waqt. Then 3 din baad, when the patient goes into the ward, the sentence never is ki Dr. Bhagwan hai. It is always said, he's a good guy. And then 2 days later, when the bill comes, he's shaitan. So within 5 days, the same guy who was treating your mother, father, brother, sister, or friend turns from a Bhagwan to a shaitan. And that's mainly because the bill is presented. The ninth cause, which is, and I'm just quoting from literature, is the lack of security that is available at hospitals. And the 10th is supposedly the negative role played by the media. So there may be multiple other causes which are local in issue. And it has always been said, particularly IMA has been proposing this for a very long time, is that there is a lack of a central law for medical protection, which is linked to the IPC and to the CRPC. I don't know, which is why this panel is here. So let me introduce some of the panel members to you, or rather all the panel members. You know the IMA representatives here, Dr. Agarwal and Dr. Ashokan. So to my left is Professor B.N. Gangadhar, who's the chairman of the National Medical Council. Mr. Guru Prasad, to my right, is the former Director General of Police, Karnataka. Professor Siddharth Mishra is chairperson of the Vivekanand School of Journalism and Mass Communication, himself a noted journalist. And Mr. S.M. and Dr. S.M. Kantikar, who till very recently used to be a National Consumer Dispute Redressal Commission member and is now an advisor. So what I intend to do is to ask each of these panelists to give to you their viewpoint on some of the points that I have mentioned or some which may I have inadvertently or not researched, missed out. So may I start first of all with you, Professor Gangadhar, your views on violence against healthcare workers.
Thank you, sir. Thank you. I also thank Dr. Sharadji and his team for inviting me to be in this panel discussion. I have participated most of the part of the morning's presentations. Very, very thought-provoking, very useful to debate on. The fact remains, any violence against healthcare providers is not welcome, has to be condemned, and all methods to mitigate this from any organizations or any other way in which we can mitigate this has to be sought after, and we must ensure that the safety of our colleagues is primary if we have to deliver the safety of the patient whom we are treating. So having said this, there are a couple of points I thought I will hear. I get some of the information from my earlier experience, both as the medical superintendent for a period of almost 5 years and the director for almost for another 5 years.
at the prestigious the National Institute of Mental Health and Neurosciences, where I have worked most of my life. And here is what I got observations from unruliness of patients or their families. Although it was very infrequent, to be very honest, nonetheless, whatever the numbers of episodes that we saw, okay, to be on a different note, although physical violence is the one extreme form, there are many other ways in which the doctors are tortured by the say, issues. One is, of course, writing in newspapers, writing in social media, trolling some of the doctors, and also complaining to the higher authorities about a doctor. Although once we go back and see everything was all right, and of course telling other patients that gossiping that this doctor is good, this doctor not good, and so on and so forth. So there are many ways of obvious violence to very covert way of disturbing the mental state of the doctor or the healthcare worker. I have observed, and most of these things I have had an opportunity to look at what was every time when it comes and when it is brought to my attention. I had a way to resolve it. That's a different issue. But when I look back, the reasons behind all these things that are happening, it's clearly multifactorial. It is truly not one issue, or is it that the same issue happened in all the people? Also, it is not true. There could be many issues which seem to be the reason, or at least the apparent reason for this situation that has happened. For example, I had to mention a few, although I'm not going into all the details, some examples like before he was referred to this hospital, what was the assurance given to him by the doctor who sent him here? Some of which may not be possible from us at all. Second thing is the condition in which this person was before referral, which ought not to have been referred at all. He could have, should have been managed conservatively for whatever the reason. And such cases, when they are referred, where of course both they and we were helpless, or they gave hopes which were not there while referring to this hospital. And on the way, there are many other preceding factors which also initiate the problem. Waiting for they call the ambulance, government ambulance does not come on time. They have to call the private ambulance fellow starts bargaining for how much he has to be paid to be shifting that patient to a given hospital. There is some tug of war, some arguments, and in the ambulance, hardly any preparedness for a patient to be shifted. In fact, most private ambulances are very poorly equipped, as we all know. But still, they take the responsibility to shift them. On bringing them here, unless you pay, we won't let your patient come out of the ambulance. All such conditions would have actually prepared the person to become belligerent when he comes to the hospital, and even on a slightest whatever may be the issue on which we might have ignored some inadvertently some issue, and all these things would give a fertile ground for violence against the doctor. Other issues which will be also relevant is what is the situation in which the illness or a trauma happened. Situations where there was a assault and there was a mob violence, or there was a group who were traveling and the group bus or something like that met with an accident. When such a group phenomenon is there, the disturbances in the hospital again increase. I can go on narrating it, but I know most of you have already deliberated many of these things. The point I'm trying to bring it across is the doctor's role is important to mitigate, but that explains only part of the variance, not the entire variance in the incidences of violence. But even this has to be prevented. There is no question at all. We as medical fraternity have the responsibility to ensure that even this does not is contributed by us, however small it is. But we all know the contribution from many other factors are definitely much more than that, and that is the reason why the IMA did take a resolution that there has to be some social or legal way of preventing or ensuring that the assault on healthcare professionals does not happen. So, and of course, on all the lectures we heard, communication, etc., has to get better. And in this context, I must place on record thanks to my predecessors before I came into NMC. They had drafted a wonderful teaching module. All along, when we were doctors, when we became doctors, when we were about to be practicing, the attitude towards patient, the way we have to communicate is all taken for granted that we are taught or we are learning from our teachers. Of course, we did, of course, learn from our teachers. But at some point of time, and of course, ethics to some extent would be formally taught. But these two components of what should be our attitude in to our profession, to our patients, and what is the way in which we are going to be communicating them. There is no formal education. I'm sure most of you who are of my age, who have been educated in the late 70s or early 80s would know that there was no formal curriculum for this purpose. We all learned by following an example. For various reasons, whether the examples came down, which is possible, or there was a need to emphasize making it into a curriculum of developing a positive attitude towards various conditions, various individuals and the profession itself, and the way we have to communicate in many circumstances. There are so many circumstances in which we have to communicate to the individual. Of course, many issues, but I'm not going into the detail. So our predecessors in the National Medical Commission, earlier the Medical Council of India, thought a curriculum has to be developed. This, I think, is a major milestone in preparing medical professionals in terms of how less they can contribute to this violence, how least they can contribute to this violence. Attitude, ethics, and communication skills have now become a part of a curriculum. Of course, the curriculum was introduced for various reasons of the COVID in the first 2 years of its introduction. Its fully blown implementation has had some challenges. But of course, most colleges are now. This module ensures in all phases of my education in a medical school, I am taught, and this is integrated with my practical skills, which happened during the curriculum, and as many as about 90 odd competencies have to be developed as part of this skill. Good number of them are knowledge and good number of them are also skills. And this, of course, we have seen this happening elsewhere outside the country, but a formal introduction in our country, I must thank my predecessors for introducing this, and this is going to happen. I'm sure this will lead to better doctor-patient relationship once this training happens. And of course, in other ways of many symposia, seminars, conferences, topics on these areas are already presented in different medical specialties. And I have myself had to participate in 2 such conferences where the subject was also one of the symposia that was meant in the national conference. So this is one contribution which I can give credit to the National Medical Commission, although not the National Medical Commission itself, for implementing the National Medical Commission, for generating a formal document, and the process for that, the predecessors, the Medical Council of India and BOG. I also want to draw your attention to one other contribution that the NMC made in its regulations. We gave for the first time right to all the doctors who are practicing a right to refer patient who is not in an emergency to another doctor and not wanting to treat him or her if the doctor notices very unruly behavior by the patient or the party. He has the right to refuse treatment. Of course, the caveat is if it is not an emergency. If it is an emergency, of course, we have bound to do the duties. But when it's an elective patient, when the patient's party is found to be unruly, we are free to refer the patient to another doctor elsewhere and refuse our treatment. Although this, once it is put into practice, I'm sure this is another way of mitigating the disturbance to escalate in the hospital where I'm treating this patient. So having said this, I'll stop here. Of course, there could be many other points that could be brought out by our colleagues in the panel. Thank you very much.
Thank you very much, sir. May I now request Mr. Guru Prasad, former Director General of Police from Karnataka, to shed some light on the way the police handles the complaints, if any, from both sides, from both the patients, and invariably it's not the patient. The patient is probably on a wheelchair or bed bound or is on a stretcher, but it's the patient's relatives. And from the medical fraternity. Because again, I'll refer to this particular case in Jaipur that happened, or in Rajasthan that happened, when the SHO of that particular police station registered a case against the nursing home and the doctor, despite the directions by the Supreme Court that the case should not be registered unless and until, there are certain caveats. Sir.
Thank you very much, sir. First of all, I must mention that all of you doctors must have experienced that police are your best friends, because like you, we are stressful, we deal with the stressful situation day in and day out, and the police are the ones who interact with medical professionals day in and day out because of the medical legal cases that we are called upon to answer. So, let me begin by telling that the police have the highest respect for the medical profession. It's from my experience that we treat like any other patient, we treat doctors as gods. So we always tend to come to the help of the doctor whenever the need arises. But as the moderator said, there may be certain black sheep in our own thoughts. I have noted down a few points. After my retirement as the Director of the Police, I worked for 5 years in a medical institution. So I have seen both sides, from the police side and the medical side. It's my practical experience that in 90% of the cases against doctors and medical professionals, they get registered because of tremendous pressure from the complainant side. It may be from a political side, or it may be the complainant himself is rich and powerful. I am given to understand that the Rajasthan case that the moderator mentioned happened because of some sort of pressure on the SHO concern. So unless there is a tremendous pressure from the police or from other sources, they will normally try to dodge registering a criminal case against a medical profession, be it a doctor, be it a nurse, be it a ward boy, to the extent possible, but because they know what are the consequences of registering that case. Because in Bangalore itself, in the hospital where I was working, one doctor was assaulted, and it was a teaching hospital. The entire medical college went on strike, and they all went to the procession to the police station, and then they sat on Dharna in front of the police station. Ultimately, the commissioner of police had to come, the home minister had to come, and that's how they were dispersed. So, unless until it is very rare occasion, they don't register a case. Number two, this normally happens once a case is registered, as it happened in Bangalore, as it will be happening in many parts of the country. Most of the complaints, whether they are doctors or other healthcare professionals, they don't bother to pursue the case. This happened in the case I will refer. Once the case FIR is registered, nobody bothers what happened later. Whether the culprit was arrested publicly, the culprit would be arrested publicly. And once the culprit is arrested and it is shown in the media that the culprit is arrested, they normally keep quiet. Hardly 10% of the cases registered in such cases go to the court and get convicted in the court. Normal rate of conviction for any case, you and I give cases compared to theft theft or cheating, only 30% of the cases get convicted. In the case of we are referring, not even 10% cases get convicted because there is lack of conviction. It so happens that people get involved in this. I know that your fraternity has been the forefront to change the laws, to make special laws after such cases were repeated from various parts of the country. But my humble opinion is that it is not really necessary to change the law. The existing laws are good enough. But only thing is what is lacking is persuasiveness. You don't pursue the case at all once the case is registered. For that reason, as I have said, that you must have somebody to liaise with the police department because you're all busy professionals and you don't have time. Once the case is registered, once you manage that particular situation, you won't be having time to see what has happened. So it's better to keep a liaison officer. In one city, some 10 or 20 hospitals can come together and appoint one person, retired officer like me, not in my rank, SHO rank or ADSP rank. He can go to the police station and find out what exactly is happening day to day basis. He will liaise and say to it that such things do not happen. One more thing I have come to realize that certain cases, in fact, my friend from the media would be able to talk better about that. I have noticed that in one particular case that there was a complaint against a doctor for misbehaving with a woman. The woman complained that she was inappropriately touched while examination, and there was no female member present when such a thing happened. So obviously we had to register a case. And then we promised that lady that we are definitely going to punish whoever is responsible for such a thing. And I said, as a former director of the police, I will personally investigate, inquire as to what has happened. But instead of listening to me, she went to the social media, put that thing on the net, and it became viral. As your friend said, it became viral. And once it became viral, an extortionist, a rowdy in that locality, he somehow saw that there is an opportunity for him to make money. He went to the media and said that he brought some 20 goals to the hospital, and there was a big suspension of the doctor concerned. They threw stones, and it was with great difficulty we had to remove them. So nowadays, what has happened is because of the pressure from the media, whether it is social media or the mainstream media, because in the televisions are 24/7, and whatever happens today, it is relayed throughout the country, and there is a lot of pressure on the police personnel that if such thing is reported in the media, now normally as there is the police, I would call and ask him, what exactly are you doing in this case? Why have you kept quiet? So that is the reason why pressure comes on them, and so we have to be very careful about such extortionists who take any such occasion for their own nefarious good, and we have to control them. When this happens, only if there is a proper liaison between the police department and the hospitals, and this can happen only if a former police officer is taken as a liaison officer by one hospital or a group of hospitals. As I said repeatedly, in fact, I have written an article in this book, which many of you might have read. In that article, I have articulated that it is the number of cases. Also, another thing that happens is police department is burdened with too many cases. In a single police station, anywhere, for example, in Delhi, they register 5,000 cases. When you're registering 5,000 cases, one single case from a nursing home or a hospital or a doctor, it normally gets relegated to the background because there are so many other cases which the police need to act fast. So that is the reason why I'm emphasizing again and again that management of the police department is very necessary. Point number two, once a case is registered, don't forget about that case till the case is properly concluded in the court. Please ensure that some of your admin men go to the court and get the case convicted in the court of law. With this, I think I have made my points clear. Thank you very much.
Thank you, sir. Thank you. Very enlightening. May I now request Professor Mishra? Professor Mishra, you've been a journalist for a very long period of time. And now, as has been mentioned by both the speakers, the advent of social media has tended to change the scenario considerably. So I'd request your inputs about two things specifically. One is the role that this 24/7 television channel is playing in perpetuating a particular case story. And the second is the allegation against the media that they only see one side of the picture, or probably they are affected by the social media campaign themselves. Sir.
Thank you, Dr. Puri. And I'm very grateful to my very dear friend, Dr. Agarwal, for having put me out on a Sunday afternoon for this session. But the telling a no treatment is very, very difficult. Support for available journalists, where the treatment comes at a very high cost and price. I'm slightly want the discussion forward. While we were doing, while COVID was on, and there was a lot of hue and cry in the field of health services and patient care and COVID. That point of time, we did a paper on communication in healthcare communication. And our findings were what created difficulties for the doctors. And please make a note of these three words. One is misinformation. The second is disinformation. And the third is, with all regrets to the lady member sitting here, bullshit. So when a patient is coming to you, you are either misinformed, or he is disinformed, or he has spread bullshit. Now I'll explain to you this further. Misinformation, the best example is, especially in the corporate hospitals or in the private hospitals, the patient who is coming is largely educated, and he has access to Mayo Clinic website. So he comes to you with his own diagnosis of the disease he is suffering from, and he counter you by saying that, look, Mayo Clinics has this line of treatment for the disease which I am having. That is misinformation. He's not really devious in his behavior, but he has gathered some information which not be very correct for his line of course of treatment, and you have to counter him on that, and you have to convince him of that, and you have to understand his psychology when he's coming to and meeting you. The second line is, about which we came up with the situation in the National Capital Region a few years back, and we had a similar discussion at the IMA hall. When a new corporate hospital was coming up here, it managed to get a media campaign run in the newspapers about the ill treatment being meted out to the patients in the other corporate hospitals of the city. Now, this is disinformation. So probably a rival in the profession is giving the patient the wrong information. A patient who is in a very, very, very vulnerable state of mind will get carried away by what that person is saying. Now, and he, being a medical professional himself, is actually feeding the patient wrongly. So this is disinformation. And the biggest problem is, and which makes the patient more ill than he should have been when he arrives at your doorsteps, is that he has fed himself and got himself treated so much by the prescriptions available on the WhatsApp. And and it's I'm sure you must have all had this experience. आपके आप पास आने के पहले वो अपना इतना इलाज कर चुका होता है कि कई केसों में वो बेइलाज हो चुका होता है, एंड देन यू हैव टू again handle him on that count. So these are more than the television channels and the newspapers today. I think these are the three. It's the social media which is causing much more problem for you, because their state of mind is largely conditioned by these three words. Either he has derived information and having himself being he might be a very good computer scientist, or he may be a very good sociologist, maybe a very good psychologist. But that doesn't mean that by reading the what you call something about a particular disease on Mayo Clinic website, he becomes competent to treat himself on that case. But he comes to you with that kind of mindset, and you have to then make him do learn what he has learned, and you have to be very, very convincing with your this thing. The second is disinformation. In most of the cases, again, you know who is the one who is playing mischief with you, and who is the one who is, what the DGP was saying, that, the rivalries. And who is creating the problem? It could be the rival doctor, it could be the local rowdy, it could be the politician who has not been addressed, it could be everybody. So there, in that case, again, you have to prepare yourself for that kind of situation. And third, of course, is WhatsApp. Now, having said that, and as the National Medical Council chairman was saying, that you have prescribed the communication in your curriculum. But as the DGP was saying, if there's a necessity to have a experienced, trained cop in your staff to take on, to interact with police, to liaison with police and other law and order authority, all the more important it is to have on your ranks somebody from the communication background. Unfortunately, and it has been I have been interacting with all my life. I have been interacting with people who are in the field of communication. We have never really gone. Even the big corporate hospitals have also not really gone about it very, very rigorously. Because it's just not about about 2-3 months back, I was with a very leading steel manufacturer of this country, and where they had the CXOs sit through 2 days of communication session. And it must have helped them, because they were handling people, tribals where they had their mines and the factories and all that. So have you ever had those rigorous communication sessions, how to counter? I'm very sure the points which I have brought forward to you about misinformation, disinformation, and bullshit you would have realized it for the first time, and you would have realized it, how it has become integral to your practice, how you are facing it on a daily basis. So it is very, very necessary for you to have communication specialists to just not only counter the one-sided story which is coming in media, because you see today social media is so huge. Newspaper has a limited space. It has 16 pages, 20 pages, 24 pages, and about one third of the pages have to go to the advertisements, and there are other news to be there. But social media is like huge. There is no limitation to the space, and it is here that you have to capture that. You have to be very, very proactive about yourself, about your hospital, about with your, if nothing else, what you call public interest messages. You do have a diabetes day, you celebrate diabetes day, उसमें अखबारों में कुछ ad आ जाएंगे, कुछ editorials आ जाएंगे, but how many people do really care to read about it? But something interesting, how interestingly can you put forward to people which engages people to know about your profession, to know about the diseases, to know about the. I think these are some of the tidbits which I wanted to share with you. Yes, there is a problem of a very, what do you call, India has been unfortunate to lose very young in his life, a very seasoned politician, a very articulate lawyer. Mr. Arun Jaitley at one such seminar had said that media or the camera loves sad pictures. So yes, which showed media and television will continue to show the sad story. It will not be it does not really, it is not part of its DNA to show very happy stories. It has been tried, but it doesn't work. Commercially, it doesn't work. So it is here that you have to take up the cudgels and capture and social media has given you that space. Social media has given you that space. It is you have to go ahead and capture that space. And one of the finest examples of that which I saw in recent time was he just retired as DGP Police Uttarakhand on the 30th of November. Mr. Ashok Kumar, human policing. And all the time, the kind of image creation, positive image he managed to create about police in Uttarakhand. Because you see, police से कितने लोग interact करते हैं, वो तो perception से word of mouth से बनाते हैं. But here was somebody who's doing an outreach, who's reaching out to you, who's engaging with you, who's creating platforms to talk to you. In that situation, people do come to change their perceptions about the profession. And if some perceptions can be changed about the profession like police, I am very sure medical profession is a very noble profession. Essentially, unless and until we have had a very bad or a poor experience, one doesn't really think bad of the doctors. So you have that advantage vis-a-vis the policeman, and it's for you again to create that platform for yourself. And again, best of the PROs, best of the public relation officers, or best of the event managers, or best of the image brand managers can't do a thing about the brand if the brand is not good. So believe me, if you're a good doctor, if you're a good human being, you are a brand in yourself. It's just that you have to be slightly careful that you are being hawked around rightly. Thank you so much.
Thank you, Professor Mishra. May I now request Dr. S.M. Kantikar, Member, National Consumer Dispute Redressal Commission, to tell us a little bit an offbeat thought, which he wants to talk about, combining some of the messages that have been conveyed to us so far from both the police side, from the medical side, from the journalism side. Over to you, Dr. Kantikar.
Good evening, everyone. We are discussing violence. For the past 1 decade, I dealt with medical malpractice and medical negligence. There are various causes of violence. The dignitaries I have discussed just now. Since morning, we have heard about why violence is there. Now I will tell negligence, medical negligence is also one of the root cause of violence. What is the expectation of the patient or patient's attendant when he approaches any hospital? Now the mentality, I may say mentality or the thought process of every patient, every person is, हमारा patient hospital गया वो repair होके बाहर आना चाहिए. This is the actual perception. Whatever it is, he might have suffered myocardial infarction or severe accident. He should come out very safely. And anything goes wrong, that will be the sparking point for the violence. Either they will beat the doctor, they will destroy the property, or they won't pay the fees, and so something happens. So now, how to avoid this? So I will focus on medical negligence only. both the topics are interlinked. There is need for ethics. We have to practice ethical practice. That is the main fulcrum. Secondly, good doctor-patient relationship. How we will develop the good doctor-patient relationship? It is the communication. In the morning, Professor Nandimat and all the speakers, they highlighted what is the impact of good communication. Many times when I was dealing, the National Commission was dealing the cases, the allegation was, doctor has not told me anything. सीधा हमें ऑपरेशन थिएटर ले गए और जस्ट ही थ्रोन द स्लिप, bring these investigations, take these medicines, and the medicines were wrong. The doctor's prescription was correct, but the pharmacist issued medicine wrongly, and that doctor has not seen, and subsequently it induced severe hypoglycemia and patient died. Then what is this? This is negligence. So this will erupt violence, and definitely the doctor or the nursing home has to face the thing. Secondly, just DJ साहब ने भी बताया, and about the misinformation, उन्होंने भी बताया. Many hospitals, even NMC also made stipulations about the misleading display of their boards. To avoid this, because patient will come, he will see the board, oh yes, cardiologist is here, so and so is here, he will go. But in fact, there is no faculty, such faculty, but these are the misleading, unfair, these are the unfair practices. So this will also land the hospital or the doctor to land into the violence. This is the another thing. So what I feel, one is ethical practice. There should be competency also. If definitely, if you are not competent, or if you can handle the Honorable Supreme Court in L.B. Joshi's case, I think in 1963 or very long back, they have defined what is the duty of the doctor. If you accept the patient, decide before accepting whether shall I take this patient. Yes, I will take. Then what line of treatment I will give, and what actually I am treating. If you satisfy all those things, then take the case. Otherwise, best way to avoid litigation, refer the patient to the proper person. So how we assess the negligence? It is just any act of omission or act of commission. I will not go into the details. Then the complaints against the doctor. Now, Professor Nandimat told the new Consumer Protection Act jurisdiction has been changed. Complainant can file complaint. Previously, in 86 Act, complaint should be filed where the respondent is. Respondent means the doctor or hospital is, or the service provider resides. Now that has been taken out. The complainant can file the complaint from anywhere. He will take treatment in Delhi, and he may file complaint in Bangalore also, or Calcutta also. Now, how to proceed further? Now, the government has made online facility virtual hearing, so doctor need not worry. What I saw in the 10 years, doctors are scared about law. Why you are scared? There is no need for fear. The police and the courts have high respects, high regards for the doctors. But where we fail, the doctors do their bona fide, they work hard. The perception of court is no doctor will harm the patient. But why there are more litigation? We are not maintaining the records. We are not maintaining our communication. You have told, yes, you come after 15 days, but the prescription is blank. He will say, the doctor has not called, the stent has gone inside the abdomen and coiled it. Removal of the urinary stent, you have to write the prescription. You come after 15 days or 1 month for the follow-up. that fails, that will be picked up by the intelligent lawyer and the litigation will start. So remember, it is in our hand. Remember, courts and police officers have high regards, police department. Now the FIR. Many times I receive till I receive the calls from the doctors. Some violence is going on, and the police officer called me in the police station. They want to file FIR. Remember, I request all the gathering, all the delegates here, keep one copy of Jacob Matthews' judgment. Honorable Supreme Court in Jacob Matthews' judgment clearly prescribed the guidelines to file the criminal complaint against the doctor. Supreme Court has given directions, no doctor shall be called to the police station, no FIR shall be registered unless it should be referred to the district authority, some expert, and prima facie, if there is any negligence, then the FIR will be lodged. So many times, otherwise, the IO or investigation officer will be held liable and prosecuted. So these provisions, what ignorance of law is not excuse. You should know the law, basic law. Now, how to deal this? Now this happened, how to deal this? Few suggestions have come. Some expert should be there, or some police, retired police officer, or some good communication skill officer should be there in this. What I feel, our society, IMA or consultant society or the associations, they form a core group of 3 or 4 doctors who will communicate with the authority or police or anybody. That will solve many problems, because violence, when the violence happens, the doctor is alone. He will try to escape or he will try to hide. And I read in the newspaper and saw in the Karnataka also many times. So this is happening. We have to tackle very diplomatically. Let us form a cell, or in the IMA, immediately call should go to our community. They will deal with the authority. Now the second thing, follow up the cases. Many times, doctor will file the case or violence is there. The doctor or hospital will not come forward to file an complaint or FIR in the police station because of the fear of the gundas. Now, if there is a committee, the committee will take the task on behalf of the hospital. They will file the complaint or FIR. And the follow-up of the case, it is very meticulously you have to follow, because एक बार case होने के बाद you will not go and the case will be dismissed for non-prosecution, or court will pass remarks, stringent remarks on the hospital. So remember, it is in our hand. We need to be vigilant. We need to be very polite and have good communication skills. Dr. Gangadhar sir told the law and other subjects should be in the curriculum. After MBBS, if I come out, I don't know how to get my registration, how to get my license to practice. I have to go to some agent. What is this? This should be taught at the base level or the final year or second year. What are your responsibility when you want to go into the practice? So all basic knowledge of law, I request NMC also to bring such in the curriculum that they should know at least the basics of the law. So with this, I think, let the forum have any discussion. Let us discuss any questions, or let us try to resolve the issues. Thank you.
May I request, thank you, Dr. Kantikar. May I request Dr. Ashokan to give the views of the Indian Medical Association before I ask Dr. Sharad Agarwal to sum it up.
Thank you, sir. I think we are coming at the final end of the session. There has to be an output other than the declaration also. So it's the perception of Indian Medical Association that the issue of violence has gone beyond a tolerable limit. And it is no longer acceptable that whatever may be the fault of a medical professional or a hospital, violence is not the answer. Violence cannot be accepted. And tolerating violence is an equal crime. The media or the society, none of them come out of, except for the medical profession. It's so sad to see that violence is condoned by other sections of the society. So there is a huge gap of, an understanding within the medical profession on how we are being treated. So the first thing is to sensitize our side of the case to even to media, to people, to politicians, that this is unacceptable. If it is legal to beat up a doctor or a medical negligence, whether it is medical or criminal, if that is going to be the law of the land, then this is a banana republic. It will not be acceptable. It will not be accepted. It's not that doctors are soft targets. It's not that doctors do not know how to handle the situation. We are constrained by history and legacy of the medical profession. Our response will certainly be sophisticated, but it will not be soft. It will be a statement of the medical profession yet to come. And no government can withstand that statement. That is yet to come. But we'll wait for some more time that we will sensitize, we will appeal, we will go through all those democratic procedures. But the time has come. Enough is enough. It's done. We need to change the laws if now laws have to be changed. We need to see that police implements if that is the gap. We also need to stop the media if they are going to be in the same line. I think, it's not that doctors are going to as sitting ducks. We are not soft targets. We will never be soft targets. We are certainly so sophisticated, but our response will be with the dignity and decorum of the medical profession. That's our response.
Sir, may I now request
Agarwal to sum up?
I'm sorry, I had mentioned that we may have time for questions and answers. I believe that we don't have the time. I'm supposed to wind up at 4 o'clock. So in case you do have opinions, questions or answers from specific speakers, you are welcome to contact me as soon as the session is over. Dr. Agarwal, please.
Panelists, sir. One second. 1 minute. I'm Dr. Joseph Mani from Kerala. I would congratulate the national president for the wonderful summit. I want to impress upon this august body that the most important fact is a stringent law. You heard that in Kerala in previous years there were so many attacks, and we fought and we had one of the probably most stringent laws against attack in the world itself. With that, the attacks has come down to zero. Now, I am bold enough to say that the attacks has come down to zero. We had the effect of stringent laws in this country. You take the Tobacco Act of 2003. When the fine was imposed on the persons who smoke publicly, you cannot see a person smoking in the public places. So there is the most important one is the stringent law, which we had in Kerala, and I request
We have given suggestion to the national government. We should get it in near future. Thank you, Dr. Joseph, for your remarks. We are discussing this morning what is the violence, why is the violence. And I feel we are very modest. Every time we sit together discussing what is the violence, why the violence, and we keep on counting our fault. We are not communicating, we are the industrialization, there is a money, there is a referral, and so, blah, 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 blah. Tell me one thing. If I am dissatisfied in the service of the hotel, do I have a right to put into fire this hotel? I don't understand. If anybody has dissatisfaction with the services, there are rules, there are law. How can be violence can be justified? Violence cannot be justified. Violence cannot be justified by saying that doctors are not communicating. It is very stringent situation for us, for the doctors. It seems like we are a sandwich. At one side, when we are working, our junior doctors are working for 48 hours continuously. No profession in the world, in the India, works like this. We have been told like you are doctors. You are like God. Patients are, you don't treat them as a patient. There should be a human touch. Then the relationship. And other side, they are putting it under the CPA. They say, no, patient is a customer. I am confused to understand what I treat. Should I treat a patient or treat a customer? Because for customer, why there is no discussion about there is a problem in the profit. The drugs are making this much of profit, doctors are charging that much of money. Why we don't discuss that hotels are charging a cup of tea who is in just 5 rupees outside the hotel, we get 100 rupees. Why we don't discuss the any industry who are making so much of profit? It is like because the system is failed. The government or any part of the judiciary or administration, combat their failure, they put everything on the doctors. Yes, as Dr. Sogan say, we have to be very gentle, we have to be polite, we have to be dignified, but we will not tolerate violence. We will not be dignified if any violence is there. Either one side, the government of India, they hesitate to make a stringent law. They can make that law during pandemic because it suits them. The virus in pandemic is affecting the governance, affecting the government. Because of that, they made a law. But why can't they convert it into the normal situation? If the violence is not justified during pandemic, it is never justified in any condition. And second side, they are making very simple process for complaining against doctor. So one side they are not able to protect the doctor, and other side they are promoting the complainer, doctors. That is happening. That should be stopped. I think enough discussion has happened that why violence is there, why the violence is there. This kind of things are happening everywhere. See the airlines. They are cheating the customer like anything. Where to go? There is not any communication. Are you able to communicate any official of the airlines? Now they sell the seats also. You are not able to communicate. So it is not the communication. It is the mindset of our government. They don't want to protect our doctors. They want to use their doctors only. And IMA is very clear on this. Violence is a very serious issue for us. As I mentioned earlier,
Violence is our top priority and we will not left any stone unturned. We will fight tooth and nail for the violence. Enough is enough. Yes, we are ready to improve ourselves. We are ready to accept that we will not communicative. We are ready to accept that we will be transparent, but we will not tolerate violence, even if we are not communicative. That is not the answer. That if we are not communicative, everybody has the right to do the violence. There was an era when I used to study, or probably the senior people sitting here, they used to study. We see the professor, the stature of the professor. They hardly used to talk to the patient. And those days it was perceived as little talk a doctor, he is the biggest doctor. That was the perception those days, and hardly any violence. So this is wrong that communication is the root cause of the violence. This is not the cause. The cause is because government, media, everybody, they are promoting complaints, promoting the violence. If there is a stringent law, everybody will not try to do the violence. Like we put the locks in our house when we go out. Locks are for whom? Locks are not for the habitual criminal. Locks are for the normal public, the bypasser public. They will not come into your house. The same apply in the violence. If we have a stringent law, then everybody will not go into the violence. The ratio and the percentage of violence will decrease like anything. I think we should stop discussing this, that what is our fault. We know our fault. We have to discuss and we request all the dignity of the society. They should make this society, they should make an environment to protect the savior. If you will not protect your savior, where will you go? We should respect the doctor. 2 decades back, for a small thing, chronic disease, we used to go outside the country and paying hefty amount. Half of the population dying in our country because they are not able to go outside the country for taking the chronic disease treatment. You don't have the respect for the doctors and the hospital. Now you are getting all the treatment is 1/10 cost of the Western countries. Then I think the scenario should be changed. The first and foremost thing, there should be a stringent law against the violence, against the violator who are doing the violence. That should be the discussion, and that is what we are going to send the message to the government. Thank you very much.
Since much the president-elect and the president have said enough is enough, I get the hint. So thank you very much. My job is now to thank the panelists. All of you have done a wonderful job in sensitizing this audience. I must say that I myself, I'm going to go back far more enlightened than the person that walked into this hall. Thank you, sir. Thank you very much. Thank you. And thank you for being a wonderful audience.
I would like to thank the chairperson and the co-chairperson, as also the expert who have made this panel discussion a very, what shall I say, invigorating and that will have to be chairperson, please.
Very brief and very meaningful. Sir, Dr. Chodagawal, your panel speech was too emphatic. But one thing you have not blamed the political wisdom of the nation. They are not serious. How do you expect? I mean, lots of time. People not really and डॉक्टर डॉक्टर क्या आपके बच्चे डॉक्टर भी बन रहे हैं डॉक्टर्स and honestly, how many children of doctors not even 20-50%? Medical doctors becoming practical. On one side, we are becoming medical superpower. One side is becoming medical tourism destination.
And on the other side, what is happening to us is painful. We should change it. We must all be together. Thank you.
Vinay sir.
Thank you very much for your valuable time for entire day. You made it successful and we are going leaving this hall with a positive message. I will request Dr. Vinay Agarwal sir to please conclude. He is the chief advisor of this entire health summit, the brain behind this. And Dr. Vinay Agarwal sir.
Thank you. I'm sure from 9 a.m. till 4:30 today, you all have been witnessing the various aspects concerning violence in the country, and also the by our leaders and the line which they are taking on the issue of violence. I'm sure we need to regarding the violence will be long way. Some sort of outcome of today's meeting, and which will be as such, will be go to the press, go to media, also go to the politicians, go to our medical member of parliament, also go to the authorities, whether it is health ministry or others. I am very confident that the support which you all are giving today in such a large numbers coming all the way from every corner of the country. So I thought like friends of medical profession coming on very as the Mishra has said, it's their time. I am very confident friends like Dr. Mishra, friends like another medical profession, Narottam and others, we will achieve what we want to achieve. I am sure even central of levels violence can be a deterrent. We need to organize ourselves to see that what kind of a support we can harness and we can harness our friends, our district members at the time. And this is the responsibility of each and every branch that you organize self-defense groups, and those self-defense groups, as rightly said, will be the groups which will not lead the individual in violence, but will be there to support the people. Thank you very much. Thanks a lot to everyone in front of you. It's a lot of group photograph. And I request the panelists who was seminar to come for a group photograph. Thank you.
Sir, Vinay Ghosh, आ जाओ.
I request Dr. Anil Naik sir, Bali, please join as a group photograph.
कुछ बोल दूं मैं भी?
हाँ बोल.
Doctor, I just want to say that we will take action. Nature doesn't indefinite strike across India. And they should improve a lot and so against the situations or against the taking process. And fight against this is fight against doctors. I can see that and also five times the fees paid. Not that they charge schools while they pay thousands. Thank you. I mean, in the white paper, this present one new paper value which is creating value for the numbers of the investors. That is also including how to do the fast reviews and what type of planning should be going to very under the plan of it. We don't have a plan, but we are depending on the strong but we can do in the profile. Thank you.